ultrasound we need to stimulate, because in even the transfer of one blastocyst only results after we stimulate. So spontaneous cycle is still a question. Control of culture, media, and laboratory procedures is essential. This we all understood. And I'm happy to have Ali listening to the lecture, because we are really 50% clinicians, 50% embryologists. Effect of CO2 on oocyte quality with laparoscopy, that was also considered. So now we do transvaginal ultrasound-guided follicular puncture, and this was developed, but it took some time. Now the step 2 was the years 1990 till 2000. So you see, IVF was around at that time. It was a time of pharmaceutical advancement, better fertilization techniques, ultrasound-guided embryo transfer, and vitrification started. At that time, the slow freezing was already substituted by suggestions of vitrification. We could not yet vitrify oocytes, but we could vitrify embryos. We started with the subzonal injection technique, and then it was found that the intracytoplasmatic sperm injection has better results, a very big improvement of all the technologies. Pregnancies from human pre-implantation embryos sexed by a specific DNA amplification was published by Handyside and his group in 1990. So then we had all the techniques of sperm extraction and in vitro maturation, and GnRH antagonists came right at the end of this step 2 into international discussion. It took a while till they really settled. Now, what happened from 2000 to 2010, as I call it as a step 3, technological improvement and international knowledge transfer, protocol improvements, donor oocytes and donor embryos were injected into the whole discussion. In some countries, they're still banned. In Germany, we cannot do any donor oocytes, no donor embryos. That's by law prohibited. Other countries have no law, are more free to that. Surrogacy took a big place also in India, now more protected again. Cryoconservation of ovarian and testicular tissue. So all this was developed in that, let's say, decade. And then final step 4, that brings us into reality of today. Freeze all concept is discussed, should we freeze and transfer only in the next cycle, one of the next cycles. What are the dangers? What are the advantages? We'll discuss that with you. Genetic testing with NGS, where are we today? We will discuss that, because that can screen a lot. Can it screen all? What can it screen? Inheritance of disease by ART. It is also discussed in COVID times, and we have even publications on that at present. Medical tourism developed, third-party involvement, and finally we have COVID-19. What impact does it have? Artificial gametes and artificial placenta, that's kind of a futuristic aspect, but it's also a present aspect. It is materialized in part. So this was a review on the 40 years. Now I come back to current techniques. What are we doing currently for non-implantation and abortions? We will have special 4 lectures on that topic, so I'm just making it really short. What has helped? Immunological diagnosis, hysteroscopy, heparin, aspirin, lymphocytes, immunotherapy, HCG, estrogen, and progesterone supplementation. The chapter of veterinary medicine. What can we learn from them? What should we not learn? What should we understand? What is cloning? What are chimera? What does nuclear transfer? What is artificial placenta? Mice can be born totally in vitro. What are artificial gametes? Sperm can already be produced in vitro. How about eggs? Also, they can to a certain limit. Embryo transfer, how can we improve that? So this would be special lectures to learn about. In Germany, we have annually meetings between human and veterinary doctors in reproductive medicine since 1972. So that's a long time, all my medical time along, and I always learn in these meetings. It's very interesting. The 4th leg between gynecology, andrology, and veterinary medicine is then basic research. Basic research incorporates embryology. So embryo selection, sperm selection, oocyte selection. Embryoscopes we have today blastocyst transfer, vitrification, oocyte embryo cryoconservation, cryoconservation of ovarian and testicular tissue, sequential media for blastocyst and embryo culture. We have polarization microscope that judge the zona pellucida, so the so-called zona imaging. So we have come ahead in these 40 years, but also in general medicine. Just imagine, maybe you know the name of Rudolf Virchow. He described many early viral and bacterial technology. So in 1898, he said to his audience, looking through a loop, "Gentlemen, through this loop I can see the whole world." Well, he was wrong in two aspects. One, that today we have also ladies sitting here. It's not only gentlemen, it's ladies and gentlemen. Secondly, is not one loop. We have loop systems in our microscopes, in our optics for laparoscopy, hysteroscopy, and so on. So always there are new developments and we have to go with them. This was our first IVF time-lapse video. A Swedish photographer at that time spent 3 weeks with us to produce that video. It was a very tedious and difficult job. We can see here 2-cell stage, developed into 4-cell stage, 8-cell stage, and finally to morula stage. And that is a work at that time. Today, we can see these developments in the embryoscopes, in the time-lapse laboratory, and mechanisms for that. Every morning, the embryologists can see how the division of cells was at night. So we have an advantage by using these embryoscopes. And I just wanted to show that video and share it with you. Times a day, and this has taken weeks to come to the stage of the hatching blastocyst. So today we have the time-lapse photography, and every morning the embryologist can look how the embryos developed, and that takes some time. It's a new job for the embryologist, but it's a good job also because we can see if an embryo has divided nicely or if there have been some cell division that are not so nice, to select the best embryo to be transferred and which we can decide which we freeze and so on. So embryoscopes have added, they bring more work. It is still not finally discussed if they really help in better results. I do think they do, but the final discussion hasn't taken place. So my dear colleagues, there has been, besides all this technical progress, a demographic development in many countries. You can see that in Germany, for instance. In the year 1950, we had a broad generation of young people supporting the older generation. Few reached the age of 80 and 90. In 2001, we could already see that the younger generation was getting smaller, and the older generation was taking ahead. Now the prognosis for 2050 is that the young generation will be really much smaller. Why doesn't it not go? Yeah, here. And the middle generation is also smaller, and the older generation, the 70 to 100 years old, are getting more. Medicine has improved. So we need, of course, to improve the younger generation to carry the older ones. Otherwise, who is going to take care of them? So tendency in the world till today is always less babies. In Germany, that's very evident. If you look at our baby statistic of 1946, we had a rise after the World War II and till 1965, and then we had really a going down. So this is only a statistic till 2010, but it shows you that the rate of live-born children and of children that died was really going down and even. So IVF has to catch something, has to go up. And this was our first press interview. After the press interview was Patrick Steptoe on the German television in 1983. So he came to see us after finally we had our first few test tube babies. And there was one visit of Robert Edwards with our group, with Andreas Schmutzer and Klaus Dietrich and a lawyer with us upon one of his visits. So we are happy to have been with the beginning and to be still with it. This was a picture of our first C-section, of our first test tube baby, and the whole team working with it was, of course, very much engaged, and everybody wanted to be on that picture. So the present aspects, ladies and gentlemen, includes in vitro maturation for normal cycling in PCOS patients. We do that in some patients, that we collect the oocytes already at day 6, 7, and let them fertilize, let them mature in vitro. We will have a lecture on that and discuss that. Cryoconservation of oocytes, consequently cycle transfer, freeze-all concept, advantages. Disadvantages we'll discuss. Cryoconservation of ovarian tissue, testicular tissue, single embryo transfer, and cheap IVF. What are the topics for the next 10 years? Once we hopefully have overcome the crisis of the pandemia. Artificial gametes and placenta, that will go on. Prenatal diagnosis and intrauterine surgery will go on. Stem cells, a lot of new hopes are put into stem cells, and there are advances. IVF, ICSI, embryo transfer, sex selection, next generation sequencing, embryo selection, in vitro maturation. That goes on. Gene codes, proteomics, we will be able to discover more and screen better. All we want is artificial reproductive technologies with healthy mothers and babies, reduction of overstimulation and multiples, and we would like in all the countries insurance paid IVF and ICSI. In Germany, we had till 2004 everything paid. Then came the big drawdown, and IVF and ICSI was not paid anymore. Single embryo transfer has lots of advantages and is what we aim at, with the same pregnancy rate as physiological conception. Freeze-all and single blastocyst transfer in unstimulated cycles at present time has a high rank and is discussed in all our international also webinars. So let me finalize with the definition of ovarian reserve. What is the ovarian reserve in a female? We discussed one oocyte. So it is the total number of healthy immature eggs in the ovaries, and the number of healthy eggs decreases as a woman ages, which can lower fertility. This may be caused also by smoking, certain anti-cancer treatments, surgery to the ovaries and other organs of the pelvis. So we have to be very careful with our oocytes. As you can see by the graph below, by age of 35, a woman's chances of conceiving per month is decreased by half. The downward slope continues until by age of 45. The natural fertility rate of the patient is therefore decreasing. So the golden age between 26 and 20 and 30 is still to be considered, as at that time the aneuploidia risk is low, but it increases with the age from 31 till 43. Then we have much more aneuploid oocytes that cannot be fertilized. So if we think about freezing some oocytes of a patient, we have to be aware of the key questions: options, optimal age, survival rates, how many oocytes, we expect a good pregnancy, cost effective, and how is it done. So it was found that the optimal age would be between 30 and 36, and the survival rate is lower in infertile patients, and higher outcomes are achieved in young and healthy women. So if we freeze their eggs, the pregnancies occur much more frequently. The optimal number of oocytes to freeze are at present time 15. A pregnancy rate up to 37% when 15 oocytes had been collected can be promised. So it is good, if we want to freeze oocytes, do it below the age of 35 or 36, and to freeze at least 8 to 10 oocytes, because the fertility in older age is more difficult to achieve. So this is a topic for endometriosis patients, for cancer patients, for patients that do not react, for patients that are not married, that don't have a husband inside. It is a big discussion. Just carry in your mind that how fertility decreases and how miscarriages increase by age. And that is something we cannot change at the present time. And therefore we check our patients always for their ovarian reserve, the endometrium, the ovary, the hypophyseal hormones. And we can say this patient is a high response patient, she's a normal response patient, or she's a reduced response patient. So we will go into details of that and discuss the antral follicle count and FSH, the so-called ovarian reserve. Where does it come from? It comes from the ovarian cortex. So we have to be careful with this ovarian cortex in any procedures we do, as we know that endometrioma resection, for instance, decreases H levels. There's nothing to discuss about it, does it? So do it carefully if you have to do it. And think about that it may be better again after 6 months, but it may also not be. It is very important to repeat the AMH levels after 3 months. Caution to surgeons, surgical treatment could exert a further detrimental impact on ovarian reserve, and bilateral disease is worse. So this is the basic that we are going to talk about in many of our lectures in the next days. Poor responders, normal responders, moderate, low responders, and high responders. How do we treat them? What stimulation scheme do we give them? We know that at 20 weeks of gestation, we have 6 to 7 million oocytes. At birth, only 1 to 2 million. At puberty, 300 to 500,000. And around the age of 37, roughly 25,000 oocytes. Around the age of 51, the average age of menopause in the United States, that's a publication, roughly 1,000 oocytes. Since diminished ovarian reserve is diagnosed by blood tests measuring hormone levels and not by counting eggs, it's hard to determine the average number of eggs of someone who has the condition. Stimulation protocols have to be adjusted to diminish low, normal, or high ovarian reserve. So we stand, according to our old Greek colleague, medical doctor Hippocrates, in the moment to say, whatever you do for the patient, do not hurt anyone. And with this, I would like to thank you for your attention and always welcome to the Kiel School of Reproductive Medicine in Kiel, Germany with our present team. Thank you very much. I will stop sharing. Okay.
That was a wonderful lecture, very nicely concise lecture on your journey from the beginning till what we are looking at in the future. Uh, right now, I don't see any questions, but on your thought process, there is a community in India which is called Parsi community. They
Yes.
come from Persia. So
Yes.
they are declining in their numbers. So
Okay.
they have started an organization by the name of Geo Parsi. That
Okay.
means Live Parsi. And
Right.
everything from oocyte freezing to IVF to any number of cycles of IVF is funded by that organization. They don't have to pay anything
That
just
is
to conserve their community.
very interesting. Hopefully, it doesn't take overhand. That they will also use the oocytes or sperms preserved for patients in the age between, let's say, 25 and 45. Because if that's the case, it's just very good. It's nice. So, as I said, from this basic concept, so many different questions are coming out, and like all the cancer treatment and what to do when someone dies and there are embryos preserved, the oocytes preserved. So that all comes from that pool. And I just wanted to show with this introductory lecture where is our present stand and where we are heading to. And then we will just go to the next lecture, which
I
is
can
Dr.
see Karunakar. I think he came and went. Is he there?
Kamalak. Have you
Yes.
arrived?
Hello.
Hi,
Hi.
I'm inside a clinic. I told my staff not to interfere for next 45 minutes. Yeah.
We hope that they don't interfere. So you're very welcome, Karunaka. And we have introduced you partly, but it's better you take this, share the screen, introduce yourself, and then give us your nice lecture.
Second lecture is mine, right? No, okay.
After
Sorry,
that.
sorry. It's Karunakar's, yes.
Karunaka's, yeah. On the
So
recent,
am I ready to okay to start?
yes, you can start.
Okay, just to confirm, my audio and video and the right slides on display.
Yes, go to presentation form, please. And very welcome to our panel.
Is it the right screen?
You,
Yes.
Yeah.
you have to go on presentation mode.
Yeah.
Yeah.
It's fine. So this was, yeah. Hello, everyone. I don't know how many audience are there, and This is Karunakar. Thank you, the faculty. Thank you, Yasin. Continue to preserve my teaching habit, I would say. I'd love to, without teaching, I'll go mad. So it's good that you're giving opportunity, and thank you for the international faculty and my beloved colleagues and teaching faculty here. Um, I'm Karunakar, originally from Tirupati, South India, and studied in Delhi for 6 years at AIMS. And then since 92, I'm settled in UK. I'm a visiting consultant to Dubai. I live in Cambridge since I joined Bone Hall Clinic, where you all know IVF began the journey. And since 2000, I live there. So I come here every month for 3 weeks and I go back with family to there. I'll be glad to share my ultrasound desire to do ultrasound skills started from AIMS, and then the IVF skills started from 2000. So whatever I say is from whatever I learned, and what I learned from quite a few significant people who have good research and training experience in this field. And I will be blending what I know from patients' experiences, where they taught us how to practice field of ART in a particular way, which is more realistically useful for them rather than talking like an academicians or lecturers and so on a research basis. I would try to cover in a way that what would benefit the patient and what would, as learners or the practitioners of IVF you're listening today, how you can implement the skills that perhaps might come handy on what I'm going to present. So I'm right now in Dubai. This photo's shot a week ago. So I will say, whatever test that you have, idea is to, the title being, to minimize the number of visits to ascertain the problems, what is stopping a couple to become parents, and reduce their cost and reduce their waiting time. And at the same time, maximize the information that you obtain to understand what is or single factor or a multiple factor that is stopping them to become parents, and to minimize the cost of whatever additional tests you are doing, minimize the number of amount of time, and then come to a consultation where you can give them the truthful information, what science can do, what your clinic can do, what the location that you are in can do, what the resources of the patients can do. So I believe as much as of these things has to be uh, put on the platform in the beginning of the journey of ART, because some people take 20 IVFs to have one baby, and there are people who've done more than 20 IVFs, they're not pregnant. So one doesn't know at the beginning of the journey. So it's better to minimize the length of the journey by maximizing the information with the least possible number of visits. So these are all Care Fertility. I proudly associate in UK still. I started with them in 2010, which has the highest implantation rate, which means clinical pregnancy per embryo transfer, every embryo transferred is implantation rate. That is highest in this company. So, and Simon Fischel, who is the owner of this company, is almost inventor of the Suzy, which accidentally became ICSI. So I work with the pioneers in that way. Coming to the tests that are at your disposal, you need to know how useful the test is. And even if the test is normal, patient may behave differently. So that is specificity. So, when you say it's abnormal, what you're overestimating. When you say it's sensitive, how much you are underestimating. So you need to know the tests that you have, the gadgets that you have, your training, your protocol, your resource limitation, your investment. All of them will dictate your sensitivity, specificity of what you're actually telling the patient, what actually turns out to be. To assess fertility in a single stop is not an easy ask. So you need to know what exactly I meant by one-stop fertility assessment service. It may go to 2 stops or 3 stops, but for majority, we can minimize into one, where you want to know the couple's ability to create a competent embryo, which means to create a blastocyst, which has got all the 46 chromosome, and also it has got a cytoplasmic competency, which can be adjudged by mitochondrial score system. Second, you want to ascertain a female ability to accommodate and feed a baby, which is the understanding the uterine anatomy, endometrial anatomy, and uterine vasculature, and the other associated uterine physiological deviations and pathologies. And of course, adnexa and pelvis, including endometriosis, hydrosalpinges, para-ovarian problems, parametrial problems, and so on. If possible, to ascertain the circulation through uterine artery pulsatility index. And the C component is how the A and B will interact. We need to put efforts to do any assessment, which can give us a clue, either on medical history or any other test that they have done, reports that they have, or your own study on understanding, is there any issue in terms of the baby's ability to invite an embryo, feed it with a good blood supply, not to have thrombophilia, not to have immune intolerance, and so on and so forth. So we categorize the C into type 1, 2, 3, 4. They're all involves about how well embryo is received by the immune system within the endometrium and the uterine area, and also, of course, the systemic immune system, and how well it nurtures it to grow a baby up to 3 kilos, 3.5 kilos, without compromising and causing maternal preeclampsia and eclampsia. So there is a way, somehow you can get some clues within minimum number of visits. And there are some special tests. We call them endometrial immune profile, endometrial receptivity array, decidualization score. There are all some special tests available. And finally, D is the diligence. You may be doctor, you can call D or diligence, or general systemic health. As you know, overweight, underweight, nutritional status, smoking, teratogens, drugs, and so on. So you can use all this information. In the uterine assessment, as you know, hysteroscopy, there are times where people only come after 3 miscarriages or 6 miscarriages or 3 IVF failure. I straight away call them for a one-stop uterine factor assessment service, which means I call them for a scan, blood supply study, hysteroscopy at the same time, and the endometrial studies, as well as endometrial immune profile, endometrial receptivity array. Whatever else I want to study, I can do it in a single stop. But that could be for a recurrent implantation failure, or that could be for a recurrent miscarriages, or could be simply they tried for 6 months, so they just want to know. So you unleash the number of tests that you do according to what is available. So interest of any fertility assessment or infertility assessment should always remember all that constitutes a healthy embryo, all that constitutes a healthy uterus and endometrium, and all constitutes the implantation, and so on. But there are 15% of couple, they will come to you. There could be problems with affordability. There may not be good expertise. That's what you are learning to become expert. There may be time. There may be issues with the gametes. So the success or failure or a miscarriage all depends on all these factors. Your test, anything should be done. I don't know how many of you are doing actually failed IVF cycles, how many people are managing expertly at a tertiary level, how many are doing at a primary care, infertility care. I wouldn't know. So my talks will overlap between all of them. It will be a general talk. My thinking is, if at all, when you finish your fertility assessment, you need to stratify. Her ability to create an embryo is in the green zone, amber zone, red zone. Same way, uterine factor, same way, the interaction factor. You should have some clarity. There may be gray areas, there may be overlap areas. What is the implication of this? When I finish doing this, some people might have had IVFs before, or IUIs before, or just ovulation induction before. Some people might have never had anything, or some people may be multiple miscarriages. I use all those factors, or they might have had 10 IVF failures, 5 miscarriages, and so on and so forth. So I take all that factors and put them into profiling, green, amber, red. Any of these documents, anybody interested, I can share with them in future. So typically I call a couple in the mid-cycle after taking a structured history, and then I do ultrasound scan, contrast scan, if necessary, hysteroscopy, and so on. Of course, male workup, I'll go through that in a minute. That includes serum, blood, ultrasound, infection screening, testicular sampling, and so on and so forth. So endocrine system, as you know, indirectly you can use ultrasound to assess the endocrine status, or directly with ultrasound, or directly doing endocrine assessment. And as I said, single stop hysteroscopy service also partly can be included in this one to understand ABC. So my universal approach is people who are having regular cycles, I call them in the mid-cycle. As you know, in theory, we know in textbooks that almost 90% of people who has regular cycles do have ovulatory type. So you can call them in mid-cycle, you can see a lot of information. If they don't have regular cycle, I deliberately put them on HRT, something similar to how you prepare couple for frozen embryo transfer. There's no other magic. I always try to do in the mid-cycle or in the luteal phase. And I take extremely detailed history. As I said, this information I can share with any of you. All this information helps me, what tests I do, how many times I have to call them, whether I'll tell them even before they come to me, I cannot help them, and so on and so forth. So detailed history is fundamental to any medical practice anyway, and certain tests are obligatory, certain tests. So male-female history goes through very detailed. Even before consultation, I email these forms to them. They fill it. So by the time they come, I directly focus on to what next. I want you to all know there's enough research done in our field that endocrine system can be beautifully represented by ultrasound. As you can see, this baseline scan at the time of menstruation, if you see no myometrial pathology, endometrium is thin, it's normally aligned, it's moving nicely, adnexa is moving around nicely, adnexa is in the normal outline, and you have 10 to 10 follicles each ovary, you have a reasonable degree and they're accessible to you. Or she walks in the mid-cycle, you see a normal myometrium, normal endometrium, normal thickness, normal position, no myometrial pathologies, no endometrial pathologies, uterine blood flow is good, there is a dominant follicle, and you can see the rest of the antral follicle, and ovaries are in the right place in the ovarian fossa. Yeah, so you get to see this in the mid-cycle. It represents decent amount of endocrine, hypothalamo, pituitary, ovarian, uterine journey of all this endocrine system at an optimal level by looking at these types of images. If in case she turns to you in the luteal phase, you get to see the corpus luteum, and then you get to see the luteal phase endometrium. I'm sure most of the people who are experienced, by seeing estrogen phase, progesterone phase, and consistently endometrium looks in this pattern, they do signify the amount of serum progesterone and estrogen also. You can always verify. Since I started my career in ART in 2000 at Bourne Hall, Cambridge, I did this work where I did manage to work around 400 people with multiple implantation failure. I did scan, contrast scan, hysteroscopy, endometrial sample, histology, all of them together, up to 360 odd patients. Then I derived this endometrial grading to practice in fertility. A, B, C, D. A is the early proliferative, B is the late proliferative until the point of ovulation. C is the early luteal, where you have progesterone somewhere between 2 to 12 nanograms, and then a late luteal, whether it is early pregnancy implantation endometrium or premenstrual endometrium, it doesn't matter. So I put this as into grade D. So this is a histology based, because all these specimens, all these ultrasound findings were confirmed by hysteroscopy, and then histopathology was done in all of them in Cambridge University at Addenbrooke Hospital. So I'm fairly confident that there is a way you can use ultrasound to understand histopathological or hysteroscopic expectation, but it should be properly seen. We call them, when they say it's homogeneous endometrium, it should be absolutely neat from internal os to the fundal strip, from east, mid part, parasagittal, mid sagittal, and right parasagittal, all planes in the vertical sagittal plane. And if you have 3D with the coronal plane and axial plane, all of them should look homogeneous endometrium. So obviously post-menstrual, pre-ovulatory, post-ovulatory, they have a high degree of correlation with hysteroscopy. And I take a lot of effort to take detailed ultrasound scan. And there are about 23 things I'm doing when I do an ultrasound scan. Once, with a good training and a good supervision and good follow-up, good auditing of your own data, which means ultrasound is a screening test. It's not a as diagnostic test as a laparoscopy or hysteroscopy. So you should all know those limitations. But if you do all three of them together consistently in a teaching hospital training, you know you can use ultrasound to a great degree as a great screening tool. And these are all the details. I will just spend some time because this is my Bible, but I'll come back to this once I finish the lecture. I'll go all the details because it gives me great degree of confidence who is suitable for vaginal egg collection, abdominal egg collection, who needs to go for laparoscopy straight away, who needs to go for hysteroscopy surgery straight away, who has a hydrosalpinx, I don't need to worry about, and then who has poor ovarian reserve, there's no PCO, who is a hyper responder, who is a poor responder, who is a normal responder, who needs a vasodilator. Of course, these are adjuvants are debatable. We'll discuss that later. So many lectures going on, how the adjuvants in embryology or adjuvants in the clinical practice or gynecology practice of ART, there are debatable issues we'll discuss. But there is a great deal of comfort I get by doing an ultrasound scan to this detail. Once with training, you will get a lot of them. Nowadays, even endometriosis staging, if you go through all ISOG learning modules on how to diagnose endometriosis, how to diagnose adnexal pathology, there is no excuse anymore not to be part of some great learning institute called ISOG, who will really stay with you until you master your skill, and your mastery will benefit in the better outcome of ART. That should be considered very strongly. Every listener should consider learning from the international speakers, the great people who really make women's life better through all the learning modules they are making available to everybody anywhere in the world. So my consultation is exhaustive. Almost 90 minutes I spend with every couple, because I go through every single thing possible in male fertility assessment in the least possible visits. These are the causes, these are the tests, and this is the female. I go through systematically. These are all the causes. what stops a female to become mother. I go through the tests, I write the costs, I write the time that it takes, so that they spend a great deal of time. I won't be able to explain all the details because this is an exhaustive, wonderfully designed course. There will be a lot of factors that I will be talking will be superimposed or repeated. At some point, I will be participating, and most of your delegates are welcome to have web chat with me throughout your next future learning curve. Whatever add value I can add, I can do it. So by taking complete details, information, and taking the history and doing all the workup, I bring them to the next phase, which is called summary 2, which is I give them options. All of them are underlined by general lifestyle, which I told you, the D. All the rest of them, which is I give them option of natural conception, the timed intercourse, ovulation induction with IUI, IVF ICSI, IVF ICSI with pre-implantation genetic testing, laparoscopy, hysteroscopy, or a combination of all this. But every treatment option I give, monthly chance, 6 monthly chance, 12 monthly chance, or what all it takes to have 90% chance of becoming parents, whatever it is, 6 IUIs, 10 IUIs, 4 IVFs, PGTs times 3, it doesn't matter. And for every journey that you're offering them, you should have a justifiable eligibility criteria of that couple. You can't say my clinic success rate is 50 to every patient who is sitting in front of you. So there is an eligibility criteria they have to meet. So just quickly brush to how much you can do for a male in a single stop. A lot of things you can do. You can see there is a normal sperm. You can see there is a suboptimal sperm. You can see azoospermia. But make sure the sperm is collected correctly, because the way the frequency of ejaculation affects, male accessory gland infections affect it. So these are the simple things. Giving right instruction how to give the sperm sample, what is the advantage of ejaculating or releasing sperm every few days, male accessory gland screening, assessment, and there's a video you can see. It doesn't take that long how to see the varicocele and do the Doppler. So I'll just quickly go through. You can see sometimes grade 4 varicocele. You can go to what is normal size testis. You see the comparison. You should know how to palpate the vas difference. Any male doctor can teach the female doctor. It's not difficult. Any male patient, you just need to practice where to see the vas, how to feel the card, and how to feel the varicose veins. Then any machine that you have, you can always see the size of the veins, and you can do just take Valsalva manure. You can see the blood taking red to blue, blue to red during Valsalva, which means reflux. So it's not a difficult skill. And of course, epididymal cyst, scrotal ultrasound, all these are very much learnable skills for anybody who is a good gynecologist doing so many surgeries in gynae ops. It's not difficult. We also can see this other spermatic cord problems at the same time. They're all relevant if you're practicing andrology also. So these are the YouTubes you can get to see anywhere if you wish on the YouTube. Now, when you say there is a normal semen, please explain to the male or the couple. Normal sperm means that we know the competency of the sperm to a 30% degree only, because we don't do routinely. We depend on, we stop here, count, motility, morphology, and we don't do even chromosome content. You're not doing DNA fragmentation routinely, or you're not doing sperm screening routinely, because sometimes some andrologists think the round cells, they call it as immature sperm cell, it may be actually white cells. So there is no harm reducing the cost of sperm culture and doing a clean specimen and rule out the culture, because this can go a long way. Even ICSI can failure if your infected sperm is being injected. So some top centers all over the world, they do routine semen culture as a routine semen analysis test. And if you reduce the cost of DNA integrity test, it could be there are 6 tests you can do. If you can reduce the cost of DNA fragmentation test, it is also a worthwhile exercise. I will justify why you need to include as a routine test. But there are so many things, almost a kind of 60 to 50% of information about the competency of the sperm cannot be analyzed by a greatest looking semen analysis parameter, because we don't know the fertilization ability of the sperm. So I always tell people, you can do general genetic Y deletion karyotype. You can assess the hypothalamo-pituitary axis by blood test. You can examine the testis. You can examine the rectally, seminal vesicle problem, prostate problem. You can examine the varicocele, and of course, semen culture. You can do as many things, and vas exclusion of the vas closure. You can see the morphology of the sperm, but these are all basic. You need to understand maybe 30-40% of the knowledge you have. But once you know it's azoospermia, you should know how to do blood test, how to decipher. Almost 90% of people with normal FSH and normal testosterone, whom you don't see the sperm, technically you can help them to find a sperm that can create a healthy embryo. Of course, it will cost. And almost, I'll show another slide, what percentage of people with testicular pathologies leading to azoospermia can be benefited. I'll give you the statistics. Again, if the hypothalamus and pituitary is at fault, it's very simple. You just replace what is missing. They can just produce the sperm. So there is a very well-written, well-researched guidelines available from many textbooks, many authors, many speakers. Today you get to hear this next 4 days. And ASRM guidelines, ESHRI guidelines. You know, the information to help patients is very much available to you. Videos, PowerPoint presentations, SlideShare.net, courses, webinars, millions. But you need to have fundamental attitude to minimize the number of tests. It's not a rocket science to practice andrology. Yes, you may not be doing or licensed to do micro TZ. You may need to do third micro TZ. That's a different matter. But approach correctly. What is the ABCD approach to male infertility, female infertility can be immensely mastered with one or two visits. This is, again, erectile dysfunction. If you're a female doctor, most men may not volunteer depending on the demography where you're practicing. So you need to take that extra care because there are so many people with erectile dysfunction. They're not ready to be counseled or improved. I just ask them to masturbate, give the sperm sample. Wife will put it in the vagina. It's called intravaginal self-insemination. Till date, I have around 23 pregnancies only on this technique over a period of 20 years, of course. It's a long period of time. But I'm very glad that I don't do IVF because they can't have sex. I don't do such things. So the point is, you can understand what causes erection, what causes emission, what causes ejaculation. If you spend 1 to 2 good quality hours, accordingly, you play the game of managing the parasympathetic, sympathetic, and somatic nervous system. And of course, give the confidence. You tell them to manage erectile dysfunction, don't need to be a super duper andrologist. There's only very few andrologists in India. I know starting from Rupin Shah onwards, Malhotras, and there are so many now. But at least in the beginning, when Dr. Rupin hasn't started andrology, it was a tough ask. Urologist doing whatever, renal stones, pancreas, prostate cancer and TORP. They used to limited approach used to have andrology. Everything used to be fine needle lab biopsy. But erectile dysfunction is rarely successfully managed, but there are alternate ways. Again, as I said before, you should know up to 67% of people you can help in azoospermia. Help to find a sperm. It doesn't mean the sperm is euploid. It doesn't mean it will produce a good embryo. It doesn't mean she will have no miscarriage. We are not talking about. I'm saying azo means no sperm. 67% of them, you can find a sperm. That much information you should give during your first consultation to an azoospermic people. Again, if you take 2017 onward literature, you should share this with also. If there is a high DNA fragmentation or there is a problem with the ejaculated sperm, you can use the teaser sperm and you can produce better pregnancy rate, low miscarriage rate in this type of people, where we consider testicular sperm is far more less oxidation damage, free radical damage than compared to the ejaculated sperm. So varicocele, as I said, is not difficult. A lot of people believe in improving sperm quality, either for spontaneous conception, reduction in the miscarriage, percentage of sperm you will find from micro TZ, and the clinical outcome, and the live birth rate, and the miscarriage rate. So people who believe in this, not everybody believes. If you see database, whole Europe is about finding not good enough evidence. There is not level A evidence, level A recommendation, level B recommendation, level C. But the problem is, not everybody can afford a high level of treatments. So there is a proportion of people where varicocele surgery done by selective, with microscopy and selective indications, there is a significant role. So you should really consider that and you should really take advantage. Of course, there is a role of antioxidant, but selectively it has got a role. So 3D, I have a lecture on ultrasound in ART. I will come to that. I'll right now minimize the number of 3D talk because in ultrasound I can emphasize, but having a machine, having a bit of training, you can really capture the uterine structural anomalies, acquired pathologies, and so on. You can see so easily, quickly. And when, as I said, when I do scan, I used to feel my scanning skills are great. But when I started to do ultrasound contrast scan, I realized my scanning 2D scans without contrast has a limited input to the patient. So I am compromising IVF outcomes by not doing a contrast scan. I can give you a reference, published reference for British Fertility Society from one unit way back in 2010, I think, which a routine universal contrast scan improves your live birth rates. I can give the reference. It was done in CRGH, London. Dr. Paul Serol was the original author of that paper. You can see contrast even if you put a saline with an NG tube without air and see that the liquid is retained without taking a space occupying bulb. You can see polypoidal endometrium and smooth endometrium. And you can see 3D contrast scan. It almost like an aquarium, you're inside it. So polyp, if you have contrast scan with 3D, intramural pathologist with 3D contrast, it adds value. How many polyps are there? Where is the next polyp in the making? Where is the thin endometrium? Where is the thick endometrium? Where is the base of the polyp? How easy is to use myosure or a resectoscope to operate? So a contrast scan I do routinely, even in the clinic, even in the first fertility assessment, if the endometrium is non-homogeneous. This is the right fallopian tube, still image. I will show the video in a second. So I do tubal patency test as part of the one-stop fertility assessment. I used to do in AIMS hysterosalpingogram. I know how a lot of people used to hate me because it's painful. And then when I went to UK, I started to doing saline contrast salpingography. But again, I used to struggle to see the outline of in a black and white shadow. Black shadows are difficult to see. So I started to believe in the white shadows are better to see. Again, a black background. You can see the right tube. Entire 10 to 15 centimeter length of the tube from cornual end all the way to the fimbrial end spillage. I will be going back to the tube once again. I'll come to that. So ovary, obviously, you want to assess their ability to create a baby by measuring the size of the ovary and counting the number of antral follicles, ideally between 2 to 9 millimeter. It's easier to do it when there is no large cyst or follicle, corpus luteum, or any other pathology. But it's not always easy. As you know, the slide is from the World Congress on follicles and cohorts. It's 2003 in Germany, this slide. So as you know, the difference between polycystic ovary and a normal ovary being this selection, shortlisting of large group of follicles 120 days before ovulation, this process gets missing or abnormal or disturbed. So majority of the follicle should have shot down to 20 or 22 in total. It remains large number. So the shortlisting doesn't take place. That's called polycystic ovary. You see more than 12 follicles per ovary. So that can disturb your ability to do monofollicular development with or without medication. So 40 to 60, down to 20, down to 1, this process gets disturbed. So you can measure the size of the ovary in your one-stop fertility assessment. If the machine doesn't do, you can do your own. And you can see that size less than 3 as a poor ovarian reserve indicator. They're all markers. They are not gold standard tests. They're markers. More than 10 could be any reason. So there are so many publications on how antral follicle count dictate your ART prognosis. And at the same time, I assess the endometrium. As I said before, if the estrogen is between 150 to 500 picogram and there is no endometrial sclerosis, you should see endometrium beautifully like a trilaminar appearance. The minute progesterone comes, the outer 2 white lines become thicker. It becomes more thicker if it is progesterone levels are 5 to 10. But after ensuring serum levels of 500 picograms of estrogen, and you see this side of endometrium, so there is a damage in the end organ. So it could be endometrial sclerosis, thin endometrium. There are 4 types of thin endometrium. At some point, I'll discuss that. There are several types of thick endometrium, but you know the endometrium doesn't look normal. So you take help of a contrast scan, or your senior, or go ahead with the hysteroscope, or whatever it is needed. So when your experience is limited with this. Adenomyosis, quite easy to see with 2D scan. You don't need 3D, but you can see the appearance. Anomalies is not difficult anymore. I gave you examples of how to see anomalies. This was my old 2D scans. As you can see, normal, almost like a circle or spherical uterus, which suggests unicornate uterus. You can see split in the fundus. You can see widely separated bicornis, bicolis. This was my old 3D scan. I can share the new 3D tomorrow. You will see much more easy. J-shape, single unicorn, septum, normal, unicornate uterus on 3D. So interest of, first you see the ovary, you can see the tube, you assess the male, then you want to know what the B factor. B factor is, all these pathologists are B factor. Of course, hydrosalpingo is also here. You can see here, 3D, just a picture. This is the coronal plane. This is the right sagittal plane. You can see the endometrium outline here, and you can see the endometrium trying to grow into the myometrium, adenomyosis picture. You can see here also fundal area, the endometrium getting thicker, but is an intra-endometrial pathology. Coming back to the tube again, I'll be shuffling between uterus and tube. Uh, Sometimes you can see the hydrosalpinx. If both ends are tied and there is enough estrogen, enough mucus, you get to see them. And I did the presentation from London Women's Clinic. It's 100 women. To my shock, there was only one patient who had bilateral tubal block after doing 100 tubal patency tests with ultrasound. It was a shocking experience to me. And 13 had unilateral tubal block. So all in all, only 1 in 6 women had tubal contributing factor for their infertility. This is inner London. It's not a luxurious area of high fertile people. I'm talking about inner London at Harley Street. So my concept of every 10 HSG, 3 will be blocked has been rewritten once I started doing less painful procedure called air contrast ultrasonography for the tube, or air contrast salpingography. So you can see right tube, left tube, and this is my paper at Georgia Atlanta in 2007. This is the video of the left fallopian tube. Just watch carefully. I'm injecting something which has got an air. You can air with saline, air with gel, air with albumin. A lot of things can give you retention of air a bit of longer period of time in the liquid. Okay. And if you are slow and steady in your hands, you allow the tubal peristalsis to allow the liquid at 70 to 80 millimeters of mercury to enter the tube, and you allow the peristalsis to gently guide you, the peristalsis. So this is the left fallopian tube going all the way. It's almost 10 to 12 centimeter long tube, you can see, and this is the follicle, it reaching. Once you scan the ovary in the beginning, it will look gray, perifollicle or the ovarian capsule or the follicle capsule. Once you see the spill, you will see the silver lining around. So I'll just play this video. I have a large number of video collections, but this should be sufficient to give an idea how freely it's filling and spilling. I can show separate videos, how the display and the loss of contour of the fallopian tube, spilling around the follicles. There are hundreds of videos that I have. So I restrict to the time of lecture for this one. If you are interested in 3D, once you take rendering, you can see now the uterus, the midline is here to the right bottom of the screen. So let me take a laser light. Yeah. So you can see the red as my pointer now. So this is the uterine cavity, the cornal end, and you can filling. It stopped there. So it was a clubbing. I couldn't push anything into the right tube, and most of the fluid was coming through the left tube. I have not shown the left tube in this one. So 3D can also, because with less time, you just freeze it. You can share with your senior colleague while you're learning, because it gets stored. All right. So this is a long video of 10 minutes. I won't play it today, right? Or when you see the scanning, you can directly see the hydrosalpinx. You can see all these features, 2D, and you can see in the 3D, proper 3D with I can say endosalpingeal damage, thickening of the endosalpinges, fluid collection. This is the 2D, this is the 3D. And also at the same time, you see she had a cesarean section. You can see the lower segment, how thin it is, bladder mucosa, detrusor, and so on. So there is a bit of contrast mucus that helps to see this thing. So another slide of contrast scan in a cesarean section, ladies. We are always talking about scan, contrast scan with or without 3D. So this is intramural fibroid without any cavity engagement. Cavity is free, endometrium is free. And again, another example of contrast scan, you can see the polypoidal endometrium. Of course, I did the hysteroscopy at the same time. This should be the normal finding if the endometrium doesn't have polypoidal changes. This is polypoidal endometrium. I'm not discussing today the management of polypoidal endometrium. Isolated polyp management is different from polypoidal endometrium. Again, is there a value of uterine blood flow in your one-stop fertility assessment? In my opinion, obviously, at the time of implantation, the natural killer cells reshape the muscle of the decidual blood vessels, spiral arteries, arcuate arteries levels. That is pathogenesis for preeclampsia, IUGR, oligohydramnios, and even second trimester growth restrictions and so on, if in a euploid embryo or a normal, karyotypically normal fetus. So redesigning of the musculature is the responsibility of uterine natural killer cells, and the blood vessel flow pulsatility index is a very good clue. So normal systolic diastolic flow, diastolic notch, reduced diastolic flow with deep diastolic notch. Next severity is absent diastolic flow. Next severity is reverse diastolic flow. All this in very short period of time, you can master the skills. In my opinion, in my experience, reverse diastolic flow warrants active management. Diastolic notch is extremely common, particularly if you're an Indian or rice eating countries with insulin resistance. Most of the people will have diastolic notch PCO. So I don't act on that. In polycystic ovary, polypoidal endometrium is very common, so I make it a point to call them in the mid-cycle, and I make it a point when the endometrium is non-homogeneous, I do contrast scan. You can almost always correlate contrast scan with hysteroscopy. So, is there an evidence ultrasound is superior to HSG? Yes. Is there an evidence contrast scan is useful? Yes. Lots of references. Is there an evidence ultrasound-based tubal patency test is superior? Yes. So one-stop fertility assessment can help identify majority of the infertility factors of a male, majority of the infertility factors of a female. It gives an opportunity to counsel, build on those information, but we need to be flexible in medicine to titrate the number of visits. But doing lap and hysteroscopy, which is a gold standard one-stop fertility assessment in India, is not warranted in many cases. And so you need to be very empathetic to the couple. So let us provide pure scientific hope to the couple with minimizing the number of visits, minimizing the cost before even if you give the baby, not to do unnecessary IVF in a damaged uterus, damaged tube, damaged pelvis, massive pelvic pathologies, severely crippled sperm, severely crippled oocytes at an advanced stage. All this can be ascertained with ultrasound and contrast scan. Thank you.
Thank you very much, Karaka. So we do not want to let the patient stand with a rainbow. We want to have them a clear vision what's in front of them. Thank you very much. We go to the questions, and I find one question that was for myself still, so I will just answer that. How do we divide patients not diminished low into diminished low, normal, or high ovarian reserve? What protocols do we use based on this classification? And there I can only say that we check FSH, E2, and if we can do a clomiphene stimulation test better under the stimulation, we check, as also Karunaka pointed out, the antral follicle count, and we measure the anti-Müllerian hormone. Now, the negligible responders have one follicle or maximum or two, and their AMH is under 1. The reduced responders, they have like antral follicles up to 2 to 10, and the AMH is between 1 and 7. The normal responders have antral follicle counts up 10 to 20, and the AMH is between 7 and 20. And the high responders have antral follicles, a lot of them, 25 to 40, 50, and the AMH is between 20 and above. So that is the basic division that we can give. I hope it satisfied the person asking for it. Tawik asking for, thank you, sir, for your lecture. How many visits for the ultrasound assessment are needed, and when to be carried out during a treatment cycle from the beginning of seeing the couple till stating
control ovarian hyperstimulation? Yeah. So yes, Lilo, you want to answer? You want me to answer?
You answered, yes.
Yeah, it's a single visit. That was the title of my lecture. So you need to call them in the mid-cycle or assumed peri-ovulatory period. And if you think ovulation is questionable, periods are not there, in such as PCOS and so on, you give them estrogen for at least a couple of weeks and call them. Single visit.
Minu, can you take the next question? Dr. Supriya.
Yeah. Please, can you tell us the difference between TESE, TISA, and micro-TESE and PISA? I think we have a lecture on this.
Correct. We have a full lecture. Yeah.
Yeah.
So, but otherwise, testicular epidermis, testicular sperm extraction, testicular sperm aspiration, and under microscope with 12 times magnification, you do the TC, pea-sized percutaneous epidermal sperm aspiration.
Right.
Dr. Cypria Hajela wants to know, also, sir, what are the normal range of FSH-LH testosterone of a male with suspected azoospermia, above which values we can give them some assurance that we might be able to retrieve sperm on PISA and TISA?
Yeah, FSH-LH is usually less than 8. Whether when on women, testosterone is at least more than 9. And if that is the case and testis feels normal texture and size, with normal FSH, it's only 2 cases in 20 years. I did not manage to find a sperm where the FSH-LH was normal, testosterone was normal, estradiol was normal, and testis clinically felt normal, and he's well andronized. Only 2 cases. So I do micro TC also. So I find the spermatogenesis is ongoing in vast majority of the people with normal pituitary function, pituitary levels of FSH and LH, and testosterone levels from the testosterone.
Okay. The next question is, if we do ultrasound in mid-cycle, how do we determine antral follicle count?
It's as simple as seeing your pupil in the mirror. Every day you see your pupil, you can see follicle on an ovary. It's there in front of you as a black round space, like a small bunch of grapes.
Okay.
Dr. wants to know, do you routinely do hysteroscopy by 4 IVF to all patients?
I have a lecture on hysteroscopy in ART. I will be justifying 25% excess clinical pregnancy rate in universal hysteroscopy even before first IVF. I'll be justifying doing hysteroscopy routinely, universally in cases who had previous IVF failure, with the meta-analysis suggesting almost 30% excess live birth rate. The answer is yes.
I can also just underline that. With us, it became a routine. We do a hysteroscopy always before, because sometimes we find later it would have been better to do it. And it's one of the one-step assessment is also part of it.
And most important thing is, please buy whatever hysteroscope is, where in India they're coming for even 25,000 rupees. So you can just make it free, right? Make it as ultrasound chart. I'm telling you, you can pick up what ultrasound cannot pick up with hysteroscope, as long as it's a decent lens. Even 15-year-old pediatric cystoscope, if I show the hysteroscope images, it works wonders. So your urologist can use, you can use, everybody can use with the telescope. One gadget lasts for 20 years. Make it free, and you will immensely benefit in your own learning and reducing the IVF treatment failure, because ultrasound is not good enough to assess endometrial vascular pathologies, glandular pathologies, and most ultrasound machines, which are cheap or old, and you are not trained in vaginal scan, misses vast number of relevant pathologies.
In our German health system, ultrasound, the hysteroscopy and laparoscopy are free. The insurance is paying it. But they're not paying IVF, but the diagnostic features they're paying. That's interesting. Okay, you take the next one.
Okay, so what is the contrast fluid? Sorry, this is for Lilo for you. Can you repeat the classification you just gave as regards the age and antral follicular count?
So as the patient ages, the antral follicles go down. And that is why at the age of 40, we of course have physiologically less antral follicles already. So that patient will not be a hyper responder anymore. So taking the other things in consideration, age and so on, we have to put her in the range.
Right.
So I have about 5 minutes because I have to drive to another clinic. So
what you can do, Karunakar, when you have to leave, you can answer the questions. You can type and answer. For 5 minutes, you can answer now.
Okay, I can answer some of the questions, as many quickly.
There are 4-5 questions left, Dr. Lagar. Please.
I can finish answering these questions in next 5 minutes. Yeah. So what is the contrast? Can I go through, Lilo? Sorry.
Go ahead.
Yeah. So what is the contrast fluid used in 2D, 3D TVS? As you know, there are commercial preparations in India, whichever country you are, which are all approved contrast material that you use for HSG, you can use them. As I said, I used to use exam gel. You can actually shake normal saline also with air aggressively, agitate them very aggressively, and it retains the fluid. Lately, I'm experimenting with albumin containing fluids, sperm wash media. In almost all of them, as long as you can trap air in a liquid a longer period of time, even for 5 minutes, and that's all you need. You need air in the fallopian tube. That's all. Okay. What is better to do ultrasonograph day 2 or 3 in the mid cycle? As I said before, day 2 and 3 for the commencement of any fertility treatment, you must do anyway. Otherwise, you can make a wrong treatment. Whereas mid cycle, as I told you before, if the endometrium is so badly damaged, you don't encourage them to come on day 2 again because you can't see endometrium. So there is a value of doing mid cycle scan, but not as a part of fertility treatment. They're different. So both have indications. Please, in which hysteroscopy should be done? Pros and cons in both phases. As I said, I have a hysteroscopy in ERT lecture, and there are many people, many of the faculty are going to cover touch basing the hysteroscopy. We can discuss. Which varicocele? There is a lecture on andrology, isn't it? Varicocele. Someone is talking. Varicocele, Lilo. Is there somebody talking about the male workup and management?
No.
Yeah. So grade 4. And again, if you bilateral, grade 4, symptomatic, and you think that it's causing the high DNA fragmentation, which cannot be improved by your nutrients, yes. But you should have the operating microscope and you should have skills. Otherwise, you actually damage oxygen supply to the testis by doing scrupulous varicocele surgery. I have seen you can actually counterproductive by doing not so expertise input. So varicocele surgery should not be taken lightly, particularly if they are unilateral, and if there is no high DNA fragmentation, there is no clear evidence on unilateral varicocele to be repaired.
Males with hypogonadotrophic hypogonadism, do you treat or refer them to an endocrinologist?
My title in UK is reproductive endocrinologist, as is in this country. So I am supposed to manage endocrinological problem related to fertility. Obviously, some endocrine problem of male are outside the scope. I will give it to the other gender endocrinologist.
And the last question, but by Dr. Tochi Nmoye, is how reliable is saline sonography in diagnosing tubal disease?
Highly reliable. Saline sonography, as I said, saline for endometrial or contour pathologies, particularly you have a contrast 3D scan. 2D is greatly enough. Good quality 2D is as good as 3D. So it's highly useful. Tubal disease, as I said, if it is both sides blocked, you cannot assess. And saline sonography is not for tube, for your kind information. In the past, yes, we used to do saline salpingography. Still some clinicians are using, but once I use air contrast salpingography, it gives better images. Saline gives less consistent images. You can, as a senior person, you can see, but if somebody is learning from you, it's very hard to demonstrate saline salpingography compared to air contrast salpingography. That's my personal experience.
That is the experience of everyone, and I think thank you very much for your answers. Karunaka, you are dismissed. Go and see your patients.
Thank you. Thank you, audience. Bye.
And it's now my pleasure to announce my co-chair, Dr. Minu Agarwal, to speak to you on overview on all artificial reproductive technology techniques. And we thought such a lecture on the first day should be very good to bring us right into the middle of our understanding of this artificial reproductive technologies. Minu, the chair is yours.
Thank you. Thank you, Lilo. And thank you for simplifying this lecture. You as well as Karunakar, both the lectures were absolutely very good. So I shall be talking just about the overview. That means how we start the IVF cycle, how do we downregulate, how do we find out which embryo we have to transfer, and how do we vitrify. So right from the basic, we'll go till the complete embryology process. So, excuse me. So when we say IVF, that means the egg is fertilized outside the body, in vitro. So whenever the egg is fertilized, the IUI does not come in IVF because the egg is fertilized inside the body. Now, when in vitro, why do we say in vitro? In Latin, it means in glass. So it could be beakers, test tube, petri dishes, but colloquially in India, we call it a test tube baby. So although it is not fertilized in the test tube. It is interesting to know that the number and quality of a woman's eggs, they go on declining. And when she is 20 weeks inside her mother's womb, she has approximately 6 to 7 million oogonia, which is just about 0.3 million, that is 300,000 by the time she reaches puberty. So a human female has lost most of her eggs before she is even capable of reproducing. Now, when we talk about ovarian stimulation, we all know that the first IVF baby was born out of natural cycle IVF. In fact, the first IVF was ectopic pregnancy, followed by the birth of Louis Brown. Then they started using clomiphene citrate, and then they started using HMG, human menopausal gonadotrophins. So why do we need to use these gonadotrophins? Because we need more number of follicles. Multiple eggs should get stimulated because some eggs will not fertilize, and whatever eggs are fertilized, also all of them may not grow till day 3 or day 5. And as we will discuss further on from here about how to do a regular monitoring by ultrasound scan when we are doing an ovarian hyperstimulation. Now, what was happening? They were doing the ovarian hyperstimulation, but by the time they would take the patient to the OT, many patients would have already ovulated. So that was a major concern. So 20% of treatment cycles were cancelled because there was a spontaneous LS surge. So that is why they developed GnRH agonists. They were the first analogs which were available to suppress the LS secretion. The moment they could suppress the LS secretion, the cycle cancellation rates went down and clinical pregnancy rates went up. Then what do you mean by down regulation? Suppose you tell the patient, I will down regulate you and then I will start the stimulation. The patient will ask, doctor, what do you mean by down regulation? So down regulation means, I think all IVF consultants should keep this chart in the OPD to explain to the patient. The hypothalamus secretes GnRH, which acts on the pituitary. Pituitary is producing FSH and LH, which is acting on the ovary. Now, as the ovary follicle is growing, the estrogen is getting released. More and more estrogen is giving negative feedback to the pituitary. Okay, stop it. And at some point of time, it also gives positive feedback to the pituitary and asking for an LS surge. And that is how the ovulation happens. This estrogen progesterone is acting on the uterus, on the endometrial lining, and we are getting an estrogenized lining. And after some time, when there is a LS surge, it is a progesteronized effect on the endometrium. Now, suppose we can stop this pituitary from releasing this FSH LH. What will happen? We can then give HMG or FSH exogenously. So FSH is given from outside. You can either use FSH or HMG, which is acting on the ovary. Now there is no LS surge. So even if the follicle grows, the control is with us. So only when we give an LH trigger, then the ovulation will happen. The maturity of the oocyte will happen. So that is the meaning of down regulation. That means we stop the pituitary to produce FSH-LH. We make the woman kind of menopausal so that there is no effect on the ovary. Now, this GnRH is secreted by the group of neurons located in the arcuate nucleus of medial basis. This is just a technical thing from the hypothalamus, and then it is transported to pituitary by through the capillaries. Now, once you give a GnRH, what happens? Initially, there is a little flare up. That means the pituitary produces FSH-LH initially. And then when we continue to give GnRH agonist, then what happens? Then the pituitary stops producing FSH-LH. When there is no FSH, no LH, then the woman is behaving like a menopausal woman. That means in a menopausal woman, although there is increased FSH-LH, but it is not been able to act on the ovary. So the ovaries are not receiving any FSH or LH, right? So it suppresses the ovarian steroidogenesis and follicular growth. So it behaves like a hypo-hypo. What happens in hypo-hypo? There is no FSH, there is no LH. Or you can call it a medical gonadectomy. And this is reversible. The best part is that this is reversible. So patients will ask, doctor, if my FSH-LH is not coming, when will they start coming on its own? So that also has to be explained. So once we downregulate the patient, there will be reduced cancellation rates. It will increase the number of oocytes, leading to better pregnancy rates. So as I said, there is an initial flare-up effect. So that is why we should start GnRH agonist in the previous cycle. So around day 15 to day 20, if you are using a single dose, or you can start between day 21 or day 25 in the previous cycle in the long agonist protocol. So we will discuss these protocols at a later date, but the idea is to desensitize the anterior pituitary, and then the pituitary is sleeping. Then you start with the gonadotrophins, the complete control is with you, and as the follicles are growing at a particular size of the follicle, you give and trigger with SCG, and then you go and you harvest the oocytes. So you can start them in the mid-luteal phase of the previous cycle, or the patient is on oral contraceptive pills. When you do the day 2 ultrasound, I think somebody asked a question about day 2 ultrasound. In a down-regulated cycle, you will find that the endometrium is thin. Both the ovaries are sleeping. There is no cyst in the ovary. Suppose you find a 12, 14 millimeter size follicle or a cystic structure, you can do the E2 values. If the E2 is less than 50, you can definitely go and start the stimulation. So after the initial evaluation, as I said, suppression of the natural hormonal cycle, we do the ovarian stimulation, collect the oocytes, then ask the husband to give the semen sample, in vitro fertilization of oocytes, and then once the oocytes are fertilized, they are called embryos, and then transfer of the embryos either on day 2, day 3, day 5, or freeze all the embryos and transfer in the next cycle. As I said, that once we suppress uh, either with an antagonist or with an agonist, there will be no spontaneous ovulation. We do not want a surprise in the OT that we go for the pickup and we find that it has ovulated. So it is important that natural ovulation should not occur. We can either use agonist or we can also use antagonist. Antagonists, they have shorter half-life. They are again reversible. You start antagonist, you give antagonist today, and it will start acting right in a few hours. So that is the advantage of using antagonist. There are other advantages of antagonist as well, which we can discuss. Where to use agonist, where to use antagonist, where to use in agonist. There are different types of protocols, and you have to again select the patient. Once you have learned the protocols, you have to select the patient, which protocol fits for which patient, so that we have a lot of time to discuss. Now, what are the medications for ovarian stimulation? We have HMG, we have FSH, LH, and HCG. In HMG, we have urinary HMG, then we have highly purified HMG, then we have purified FSH, and then we have highly purified FSH, and then we have urinary HCG. And then we have recombinant preparations. I would like to ask you if you know the difference between a urinary preparation and a recombinant preparation. So in the recombinant preparations, we have recombinant FSH. We have long-acting FSH, which is right now not available in India, but it is again a good molecule. We have recombinant LH. We have recombinant FSH and LH in combination of 2:1, which is also not available right now. And then we have recombinant SCG. So all of them can be used. You can use urinary preparations, you can use recombinant preparation. We will discuss about where to go for urinary preparation, and is there any special indication to use recombinant preparation, or you can just depending on what is the convenience of the patient, what is the how costly is recombinant or urinary in your country, depending on that you can decide. So when we talk about urinary preparation, that means we know that postmenopausal women have high FSH, high LH in their blood, and also they are secreted in the urine. So if the urine of a postmenopausal woman is collected in this urinary dried products, and then they are separated, and that is how a urinary HMG, and urinary HMG can be purified to make a purified FSH or a highly purified FSH. And if we collect the urine from a pregnant woman, we will get the SCG, and that can be extracted and can be used to give the trigger for in cases for ovulation induction. Now, recombinant preparations are uh, uh, manufactured in the laboratory. So the advantage of the recombinant preparations, when we talk about recombinant, it is the specific gene of that particular hormone, whether it is FSH, LH, or SCG, it is done. Then placental tissue and DNA are homogenized, and DNA, they prepare a library, okay, at particular point that particular DNA is marked, and then it is inserted into the vector, and that is again inserted into the genome of a Chinese hamster ovarian cell line. And this particular molecule is similar to the urinary FSH, urinary LH, or urinary SCG. The only advantage is that we get as much as we want, because there is no limit. Number one. Number two, the batch to batch consistency is good. That means in one particular batch you may have a better quality, and in another, because they belong, it is a human source. But here, since it is produced in the laboratory, the batch to batch consistency is good. The drawback is that they are little more expensive as compared to the urinary product. Then we talk about down regulation. We already discussed. We can either give agonist to the patient, or we can give antagonist to the patient. Agonist takes time to act, so we have to start the agonist in the previous cycle. Either we can give a single dose in the previous cycle, or we can slowly give low doses every day, put the pituitary to sleep for about 1 week, then start your gonadotrophins. When you're starting your gonadotrophins, continue with your agonist slightly in a lower dose. That means you have pressed the sponge, you have drained out all the water, but you keep it pressed, so with the lower dose. So you start with say 0.5 until the day 2 of the cycle, and on day 2 of the cycle you make it 0.3, but you continue with your agonist, and then on day 2 you start with your gonadotrophins. Another thing is that you can start from day 2 both agonist and your gonadotrophins. The advantage is that agonist also has a initial flare-up effect. So it will increase the FSH-LH in the initial period, especially in poor responders, and then it will start putting the pituitary to sleep, and then you have the control in your hand, and then you can give the LS surge once the follicle is about 17 to 18 millimeters in size. And second is GnRH antagonist. In this you can suppose the patient has come today, she's day 2, she says, doc, I want to go for IVF in this cycle, I have no time to wait. Or she is a young patient, or she is a donor, or she's for oocyte freezing. So all those patients, you can start them on GnRH antagonist, you start them on gonadotrophins. Once the follicle is about 14 to 15 millimeters in size, that is the time you put the pituitary to sleep. You give antagonist, immediately it will say no FSH LH coming from the patient. The control is with you, And once the follicle reaches 18, 17 to 18 millimeters in size, 2 dominant follicles at least, that is the time you can give the trigger. The advantage is here you can use the agonist trigger because the patient has never been exposed to agonist. So if you give agonist, it will cause a rise in LH, and that is how you can avoid an OHSS. So once you have given the trigger, then the oocyte is retrieved between 34 to 36 hours by transvaginal sonography under short GA. So this is the vaginal probe. It goes into the posterior, into the fornix of the vagina. You push it up, the ovaries are enlarged like this, and you should be as close to the ovary as possible so that there is no bowel, no other structure coming in between. There is a needle over here. There is a needle attachment. Needle goes through that needle attachment. It enters into the ovary, into the follicle. Once it enters into the follicle, you start with the vacuum. So there is like a suction. So it sucks the follicular fluid, and the oocyte is sucked, which comes into this test tube. And this test tube is then put in a warmer, in a test tube warmer, and then it is given to the embryologist. So this is how all the follicles are punctured on this side, and then all the follicles are punctured on the other side. Once the follicles are punctured, usually about 10 to 15 oocytes are aspirated. It could be any number. It could be as low as 2 or 3 or 1, and it can be as many as, in one patient, we actually got 100 plus oocytes. Then these oocytes are stripped from all the surrounding cells, and then we examine those oocytes. We have good lectures from our embryologist who will tell you about the quality of the oocytes, how to differentiate M1, M2, GV. So all that we will discuss. So once they are collected, then we know how many M2s are there. Then we ask the husband to give the semen sample. And then these oocytes are fertilized. Now the problem with this was when they were doing IVF, in vitro fertilization, they were only suspended, both the oocytes and sperms together. What if the sperms are very few, very less, severe oligosteatoteratospermia? The second technical breakthrough after the IVF came in the form of ICSI. So where they could actually penetrate. I mean, I think this is the most, again, very, very major breakthrough, that you could actually penetrate the oocyte and push a sperm into it. So for the management of severe infertility, then came this successful treatment. And I think now most of the centers are doing majorly ICSI, even for a normal sperm count, but which can be debated and we can discuss about it. So in this process, the embryologist isolates a sperm cell, it sucks it into the needle, and then the embryologist injects it inside the oocyte. Again, we have good embryological lectures which will tell us where to insert, exactly how to go about this particular process. So a lot of indications we have for going in for IVF. And then suppose the husband is azoospermic, so there are no sperms. So there are few things which can happen. If the husband, there are no sperms, you do first to the hormonal profile. If he has low FSH-LH, that means it is probably hypo. You put that gentleman on HCG and HMG, and 90% of the times wait for 3 to 6 months, sometimes 9 months, and she may come pregnant to you. Second thing is FSH-LH is high and the testes are not palpable. Those are the worst cases, because in that particular case, probably it is an end organ problem, but we can still try the options. Third thing is FSH-LH is normal. You do an ultrasound with a color Doppler. There may be a varicocele, a grade 3 or grade 4, which may need to be operated on, and then that again is a viable option to get sperms at a later date. Suppose we have azoospermia, no sperms, normal size testes. You do FSH-LH, which is normal. In your mind, you know it is obstructive azoospermia. So those are the best patients. Now, this is for obstructive azoospermia. What you do is you put a scalp needle, which we call PISA, percutaneous epididymal sperm aspiration. Take some culture media in this, and you have to just aspirate and pull it out, and you will find a huge number of sperms. This is a small head on the testis, and this is the large head on the testis. Suppose it is not an obstructive azoospermia, but you are hoping you might get some sperms. You can also go for TESE. Herein again, you put a needle inside. If there is, I think I have a lecture on, I will demonstrate the videos to you. And then there is TESE, where you actually cut open the testis and you take seminiferous tubules, pull it out, and then you tease them and take the sperms out of it. And then there is microtese, wherein actually you slit the testis into two, and you watch under microscope with a lens, and you take the tissue from the highly vascular areas, which is like a focal spermatogenesis, so you can pick up those sperms. So once you have done ICSI, next day you do a fertilization check, and generally about 65 to 75%, maybe a little more. Now we are seeing 80 to 90% fertilization rates with our excellent embryologists like Goral and Professor Ali Salmasi. So they are actually giving us up to 90% of the fertilization. So you can see this fertilization happening 2 p.m. Now, if I ask you what is this embryo, this is a day 1 embryo. Which day is this? This is a day 2 embryo. Which day is this? This is a day 3 embryo. I'm so sure you know 8 cell stage, 4 cell stage. What is this? This is a compact. It is a day 5 blastocyst. So this is how and ideally an embryo would look. Although it does not always look like that. There may be some fragmentation, some vacuole, sometimes uneven sizes of the cells. So all that is a possibility. So once we have got these embryos, either on day 2, day 3, or day 5, these embryos are then transferred into the uterine cavity. One option. Second option, the entire world is now moving towards freeze all and then transfer in the next cycle. Especially when you have got, when the E2 values are high, when you have got too many oocytes, then sometimes the endometrium is not able to keep pace with the um, uh, with the date of the oocyte. So either the endometrium may be running faster, so the pregnancy rates probably may go down. So if you get lesser number of oocytes, lesser number of embryos, you can by all means transfer in the same cycle depending on how you have counseled the patient, or you can freeze all and transfer in the subsequent cycle. So for transfer, we use a Cusco's speculum. Do not use a Sims and a Valsalon, because you do not want to touch the cervix at any cost. And then there is an outer catheter which is placed first. Through this outer catheter, a small inner catheter which is loaded with the embryos is placed, and then those embryos are placed inside the uterine cavity. So we have lectures on both pickup and embryo transfer, I think today or tomorrow. So now I think we have to keep in mind a possibility of a OHSS if the AMH values are high, it is a young patient, it is a PCO patient, and too many follicles. So to prevent OHSS, we can take the patient in an antagonist protocol, wherein you start with gonadotrophins. Once the follicle is about 13 to 14 millimeters in 14 to 15 millimeters in size, add antagonist. And then the follicle is 17 to 18 millimeters. That is the time you give the trigger with an agonist, especially if your E2 values are more than 3,500 and you are expecting more than 18 oocytes. So by that means you can prevent OHSs. We are fortunate that we have this antagonist protocol with agonist trigger today with us, but there were IVF consultants like Professor Mettler who started right in the beginning when there were only agonist was available. So that was the one of the major challenges which were faced by the earlier IVF consultants. So it can be mild OHSS, but there is a small proportion which can be severe. And if we go into the literature, we have seen this is this as a fatal complication to a woman who's come only to have a child. So absolutely not accepted in today's time, but we have to understand which protocol to use for which patient so that we can prevent OHSS. Also, we understand that aneuploidy increases with maternal age, and we are getting more and more patients coming at a later date for IVF. So we have the possibility to do a PGS for aneuploidy, go for single embryo transfer, um, uh, especially in cases of advanced stage. Also, you can do PGD. That means if they have a baby who has a problem, so again a library for that baby is first created. We know where that gene is located, and then look for that particular gene in the embryo biopsy for the next pregnancy. We had done one patient for who first two children had DMD, which is an X-linked disorder, and we did a PGT. We found out of 7 blastocysts, we found only 1 blastocyst which was good and which was then transferred, and she got a healthy child. Also, there are possibilities look for BRCA1, BRCA2. There are also possibilities to look for a perfect match for the previous baby. You know, sometimes the baby needs maybe a bone marrow transfusion. So you can do the matching with the previous baby and then transfer that particular embryo. But ethical things we have to still look at for those HLA matchings. Vitrification is the next technical breakthrough because the vitrification is possible. Instead of slow freezing, we can do fast freezing, and it kind of we are able to do an oocyte freezing because the survival rates are much better with vitrification, less ice formation and better oocyte survival rates. So today we have so many patients who come for egg freezing. They are sometimes younger in age with poor ovarian reserve with endometriosis, or sometimes they are 33, 34, and they feel they're missing the bus. At least freeze the oocytes till they find a partner. So that is a possibility now with a fantastic program of vitrification. So we need to optimize IVF. There are many steps which are there, like doing a hysteroscopy, in some cases doing a laparoscopy. If there's a hydrosalpinx, remove the hydrosalpinx. So all that should be looked at before we actually start the process of IVF for the patient. Stimulation protocol we shall be discussing again, but that again they have to be individualized. You cannot have the same size fitting all. So all that we should understand. And again, what is the technique of embryo transfer that we are using? Whether we should do a mock embryo transfer for every patient, all that we need to look at. What are the complications? How can we avoid the complication, especially ovarian hyperstimulation syndrome? Again, we will discuss it in our stimulation protocols. So this is preventable complication, and we can discuss it. How to improve the implantation rates? Again, there are possible, I think one of you can maybe go into only the implantation. What are the causes of implantation failure, and how we can improve the implantation rates, which is always a big question mark in IVF. So good counseling to the couple before we start the process, for them to know the percentage of success and the rate of implantation failure is very important. And of course, vitrification, use of vitrification helps, and we can do the freezing of the embryos. We can freeze the oocytes So all those possibilities are there with us, and then we can transfer them as and when we feel the endometrium is good, or the ovaries are not stimulated. So in that cycle, when we want to stimulate transfer, we can transfer. So IVM and other things will be discussed, but those are also the possibilities, especially in patients who are facing cancers at a reproductive age group. So, and even children, where you are going in for ovarian freezing, or you are going in for along with ovarian freezing, you can remove these immature follicles, mature them, and then freeze them. So these all possibilities are there. Thank you very much for patient hearing. Thank you.
Thank you very much, Minu, for this very nice introduction to our next 4 to 5 days. And I can see that Dr. Goral Gandhi has joined us now. Goral, can you turn on can you take off? Yeah, very good. Very
Hello,
well.
hello, Professor. It's a pleasure to be here. Hi, Dr. Minu.
Hi, Goral. After such a long time.
For information, we're answering now the questions of Dr. Minu's lecture. Then we have a 15 minutes break. Then Dr. Salmasi is speaking, then you are speaking. Is that okay for you?
Yeah, sure.
Good.
Sure.
Thank you so much. So then I'll go into the questions of Dr. Minu. So the first question is from Dr. Supriya. Madam, what does GnRH agonist, what dose GnRH agonists we give for flare protocol and how long?
Okay. For flare protocol, you start from day 2. For 1 day, you give agonist 0.5, and then from the next day, you start both HMG or FSH, whatever you're using, and continue with your agonist, and you give it till the day of trigger.
So agonist you give from day 2 or 3 onwards.
Day 2 and day 3 is the gonadotrophin. Sorry.
Then Dr. Stanley Newley wants to know, what is the miscarriage risk in embryo development from PISA, TESE, and microTESE? A difficult question.
It's a very tricky question. Well, I think Goral will be able to answer how to select the sperm. So, I think that lies with the embryologist. We collect the sample and give it to the embryologist. So, if they're selecting good sperms, I'm sure I think Goral will be able to give this answer.
Here we go between the clinician and the embryologist.
But can one of you, Dr. Ali, can you unmute yourself? Dr. Ali and Goral, can you comment on what would be the miscarriage rate if we in PESA, TESE, and microTESE? It's a tricky question because it's a complex field.
Yeah.
But anyone of you wants to make a comment of our embryologists?
Dr. Ali, please unmute yourself.
How am I doing? The pregnancy rate is very low. We have a little more abortion in this field.
Okay, thank you. Okay, then next question is, for how long do we use Clomid or HMG for azoospermic males?
See, if it is an azoospermic male and it is you have done his FSH LH levels. If FSH LH is low, that means it's hypo. Only in that case, either Clomid or HMG will help. If it is an obstructive azoospermia, most of the times in complete azoospermia, they're obstructive type of azoospermia. There, your HMG or Clomid will not help. You have to keep it for at least 3 to 6 months, either of the two, in cases of hypo.
The clear answer is only in hypo males you would give it.
Right.
Dr. Kingsley Chukwu wants to know, for a patient requesting for IUI despite adequate counseling for ICSI for a semen of 1 million, is there a chance for success?
Okay. See, for IUI, total motile sperm count should be more than 10 million post-wash. Between 5 to 10 million, you can still take a chance and do an IUI after explaining it to the patient. But less than 5 million, I think you should tell the patient they will not get a pregnancy. They're wasting their time with IUI. I mean, very less chance of getting pregnant.
Any comment of Dr. Ali or Dr. Goral for that?
Absolutely. The cutoff of a post-wash count of 10 million should be taken to distinguish between IUI and ICSI. Because the female age is going to advance and, we are just going to waste the time. So there is really no point.
Okay. Dr. Rashid Taufik wants to know, what are the chances of developing functional cysts while using agonists, antagonists in downregulation? Are there any chances, Dr. Minu?
Yes. See, if you have downregulated the patient well, when you see on day 2, normally you will not find a functional cyst. Even if there is a functional cyst which is present, you do the E2 values. If the E2 values is less than 50, you can go ahead and start stimulation. But if the cyst is say like 5 centimeter cyst, then you have to hold on, wait for the next cycle and start the stimulation from the next cycle. If the patient is in a hurry to go for the cycle and you have a 5 centimeter simple cyst with E2 values not very high, you can also do a puncture just like you do a ovum pickup and then start the stimulation. But not recommended regularly, but in an absolute desperate case, you can do that.
If the patient has a, let's say, 4 centimeter endometriotic cyst, only has one ovary, is advanced age, we would of course go ahead with the stimulation.
Yes,
So
of course, yeah.
of that patient, that is an individual decision between the doctor and the patient.
Right.
What to do? Dr. Minal Chuk wants to know what to do if we have a 20 millimeter follicle on day 8-9 after stimulation with HMG or FSH.
Okay. So I don't know whether you're talking about IUI or IVF cycle. If if it is an IUI cycle and you find a large follicle on day 8 or day 9, do an E2 values. If the E2 value is not matching with that follicle, just ignore this follicle. There might be another follicle which is dominant selected follicle which is growing, and you just target on that follicle. Second thing is you can put the color Doppler, and if you do not find a very good blood supply to this follicle, you can again ignore this follicle. But if you're talking about an IVF cycle, it is unusual that a single follicle will grow to 20 millimeters on day 8 or day 9. It is because you're starting a stimulation from day 2.
From Dr. Tina Trivedi, role of aromatase inhibitors in male subfertility, dose and duration.
I personally have no experience in the use of aromatase inhibitors in males. I don't have any personal experience.
Any one of you, Dr. Ali or Dr. Goral, do you have experience in males how to use aromatase inhibitors?
No, I wouldn't know.
Well, I can say that we have used it in males for 2 to 3 months, just as a matter of tranquilizing and stimulating the testis. The result was not too convincing. Kumran Nahar is asking, is there any role of HCG on oligospermia?
Again, only if it is hypo HCG will help. But if it is oligospermia because of end organ problem, HCG will not help.
Henry Uwando is asking, at what point in the antagonist protocol do you introduce the GnRH antagonist?
Okay. Normally, there are 2 protocols. Either you can go for a fixed protocol or you can go for a flexible protocol. In a fixed protocol, you start either on day 6 or day 7. You just fix it and you start it on that day, irrespective of your sonography. In a flexible protocol, when you have 2 follicles of 14 to 15 millimeters in size, which again happens either on day 6 or 7, but sometimes on day 8. So you can just avoid using an extra injection, which has no meaning. So in a flexible protocol, you start when 2 follicles of 14 to 15 millimeters in size are seen either on day 6, day 7, day 8, or sometimes on day 9. That is the day you add the antagonist.
The Coca role of oral contraceptive pills in long protocol. You can use it.
Yes, of course. Yes. because you have to time the cycle. So in a long protocol, you can either use contraceptive pills or you can use progesterone to time the periods. So suppose you stop the pill on day 25 for the patient to have a cycle on day 28 or day 29. You start your long protocol on day 21, right? So day 21 to day 25 you stop the pill, and day 28 she gets her periods. This is the long protocol. Then we have the ultra long protocol, where you give it 5 weeks before your anticipated embryo transfer. We can discuss that, I think, at a later date, right, Lilo?
You want to time the whole program. Some people do follicular punctures and embryo transfer in a certain weeks. So they have to get all the patients together for the same timing. Then you can use contraceptive pills, stop them, and have them in more or less the same cycle. So that is a thing you would use it. Otherwise, after endometriosis treatment and so on. So, Dr. Any role of the 2LH and progesterone levels before starting stimulation? Very important question.
Yeah, Lilo, I think you answer this question because yeah.
It's fine. It's there for you.
Okay. Yes, you can do day 2 LH and day 2 progesterone. There is no harm. But day 2 progesterone actually will not show you anything. It will, it's just you're wasting the money. Day 2 LH is good because if the LH is low and you are going in for an antagonist protocol, then you know that your agonist trigger may not work. So there are some publications where they have shown if the LH values are low on day 2, in an antagonist protocol, your agonist trigger can fail. So that you must keep in mind. But normally at our center, we don't do day 2 progesterone. You can do, but I don't see any use for that. Lilo, do you do it?
If you have a patient that is not reacting, you want to really get into why, then you do LH and you find it low, then you have the consequence for the triggering.
Right.
Shinvi Ikwillo, do you give LH to old IVF patients or you prefer FSH to older ones?
Yes. So if it is a poor responder, there were, I think, a couple of publications where they used recombinant FSH, and then on day 5 or day 6, in the ratio of 2:1, they added recombinant LH, and they found a good pregnancy rates. We also have used that protocol, but then we found, number one, very costly, this protocol, and number two, we did not find a huge difference between using recombinant FSH followed by recombinant LH as compared to using HMG. So, but you can use that protocol. That's a good protocol and it can be used.
But then mostly we jump in with HMG if we say that, if we have that reason.
Right.
Dr. Stanley Nodi is asking, please, what dose of HCG is recommended in the treatment of hypo-hypo? Okay.
Yeah. You can start with 5,000 units per week. And then you add HMG. HMG is given twice a week, and SCG is given once a week. I presume you're asking for male hypo-hypo. SCG 5,000 once a week, and HMG, depending on the BMI, either 150 twice a week or 75 twice a week.
Okay, now we'll take the last 5 questions. In IUI with existing functional cysts, what is the E2 cutoff on day 8-9 to decide whether to go ahead with the IUI?
Yeah. So a mature follicle should produce between 150 to 200 picograms of E2. So if you see one follicle, a large follicle, and another small follicle, and you find the E2 values only say 70 or 50, that means that large follicle does not contain a mature oocyte. You also put color Doppler, and mostly you will find that there is no good blood supply to the large follicle. Then just follow the small follicle. But if there is a follicle and the E2 values are 200, 150, 180, then go ahead and give the trigger and go for IUI.
Dr. Kamro Nahar is asking, what are the treatment options for oligoteratoastenospermia of a male infertility?
Okay, there is actually speaking, ICSI is the only treatment. if a male has oligoasthenoteratospermia with infertility, ICSI is the best treatment. It is other antioxidants, other treatments like Professor who was with us last time, he said it is like asking to eat carrots if you have specs. So that is the only help it does.
Koka is asking when to postpone embryo transfer. That's a very general question, but maybe some cases where we postpone embryo transfer would be.
Yeah. One is if the E2 values are very high. So those cases better to freeze all the embryos, transfer in the subsequent cycle. Second is if your endometrium is not good. If you find you have the oocytes, but the endometrium is not good, then you postpone your embryo transfer. And third, of course, is the convenience of the patient. Sometimes you may freeze the embryos.
Where's the place of buserelin or loprolide? So that's the oral nasal spray or the depot GnRH agonist down regulation as against the daily dose of buserelin. What are oocytes yield in both arms? So
would you want to answer? Because I don't have much experience with buserelin. We use leprolide at our center.
Yeah, so it really depends if you want to do a long-acting cycle or we just jump in. We can use daily applications of nasal sprays, and then we use it daily. And if we go loperamide acetate, we give it either in a 1 month doses, then we give it 2 weeks before the period, and it has an effect till the triggering. So in which patients would we do that? We prefer the nasal spray many times to the injections. People feel safer with it, same effect as injections. And the depot in endometriosis patients, patient that we want to have a calm, good effect, it may require more HMG or FSH for the stimulation. So it's a second line treatment after we see we did not have success with the first planned treatment. Dr. Chinwe Okwilo wants to know, do you use didogesterone for ICOC?
Can you put the question in a nice way? Maybe you are talking about dydrogesterone. I did not get it for the luteal phase support. But can you put this question again?
Question again, what is daugigesterone and what is ICOS? Dr. Divya Arun wants to know, Madam, what is the E2 value cutoff for triggering?
Okay. See, there is no cutoff of E2 values. E2 could be whatever. You still have to give the trigger. If your E2 values are more than 3,500 and the patient is on antagonist protocol, then you can give an agonist trigger to prevent OHSS, because we know that OHSS is because of the ACG. If your E2 values are less than 3,500, even on an antagonist protocol, you can use an ACG trigger. The advantage is when you give the ACG trigger, you can transfer the embryos in the same cycle. You have the possibility to transfer with a good pregnancy rate. So, but if your E2 values are high and the patient is on an agonist protocol, then you may want to coast the patient, number one. Wait for 1 day or 2 days, let the E2 values go down slightly and then give ACG trigger. And you can give the patient antagonist post pickup so as to cause luteolysis and reduce the risk of OHSS.
The E2 values depend on the number of follicles you have.
Right.
That is very important. If you have 10 follicles, you can go 10 times 300 picograms per ml. So you have to see the number of follicles and then judge the E2, but not the E2 values alone.
Right.
We use Clomid and HMG in IVF in low resource settings.
Yes, you can, because your Clomid will also increase your FSH for the patient. So you use Clomid to increase the FSH and then you add HMG. So they have a synergistic action. So you can use it by all means.
Dr. Chinwe, how do you deal with fluid in the endometrium at the time of transfer?
We do have some lectures on embryo transfer. I think Lilo has a very good lecture on embryo transfer. But if there is a fluid in the endometrial cavity at the time of embryo transfer, you do not transfer. You have to cancel.
That's very nice if you can freeze, but if you cannot freeze embryos, like in Germany at a certain stage, then you have to do whatever, a little aspiration or something. But it's certainly the implantation rate is reduced if there's fluid. Dr. Divya Arun, Madam, natural cycle patients are asking if they can take progesterone support in the second half of cycle. Is it advisable?
Actually, progesterone support should definitely be given if you have given gonadotrophins and HCG for trigger. But if the patient has gone in for a natural cycle, even if you, I mean, you can give progesterone support, but even if you don't give the progesterone support, most of the publications show that the pregnancy rates are similar to giving the progesterone support.
There's Tochi asking progesterone support, oral, vaginal, or suppository. Which is the preferred route?
We use vaginal progesterone, but you can use injectable also. I mean, again, we have a lecture on it, so we can talk about it, various routes of administration. But progesterone level should be good when you're transferring your embryos. That is most important.
Dr. Rupal, which is give better pregnancy rates, fresh embryo transfer or freeze embryo transfer? that's
Yes. Most of the recent publications are showing frozen embryo transfers are giving better pregnancy rates when the E2 values are high and the number of oocytes is high. Where the oocytes are less than 10, those cases they are comparable. So you can decide in your center. If you have freeze all policy, you can freeze all. But as far as the publications are concerned, more than 10 oocytes, the pregnancy rates are better with frozen embryo transfer cycles. And if lesser number of oocytes, then the pregnancy rates are comparable, fresh and frozen.
So we take that now, the last question. HMG versus HPFSH, which gives better outcome and why? So recombinant versus urinary extract.
I think both give equally good results. I have not found much difference in the results as far as whether we are using HMG or we are using FSH, purified FSH, or we are using recombinant FSH. We have more or less similar results, but you should use the products from a good company. That is most important.
Any benefit in endometrial fluid aspiration few days before transfer?
No, you should not do an aspiration unless, of course, there is a fluid seen. You are not allowed to freeze the embryos, like Lilo said. Only in that case, you can put an embryo transfer catheter inside, do an aspiration, and then again use another embryo transfer catheter and place the embryos. Only in those cases. Otherwise, do not transfer and do not aspirate.
Dr. Ogunimi, what should your value of progesterone be when you are transferring the embryo? You should not be.
Serum progesterone should be more than 51, if I'm right. But we normally don't check it. We check it on the day of trigger, on day -2. It should be less. It should be less than 1.5.
And when is the best time to start luteal support? That's easy.
Post embryo transfer. Suppose you have done the embryo transfer today. From today, you start the luteal support.
Okay, so right immediately. So thank you very much for all these questions. And we will now entertain a 10-minute break.
15 minutes, Doctor. 15 minutes break.
Minutes break. Okay, 15 minutes break. I hope we've answered all the questions. I just want to communicate to you that we have participants from 13 countries, as I could find out, from Bangladesh, Germany, Great Britain, India, Kuwait, Malaysia, Burma, Myanmar, Nigeria, Oman, Pakistan, South Africa, and United Arab Emirates. So we are great to have the 13 countries together, and we are happy to now let you go for 50 minutes break and then see each other for the embryological, andrological part of today. Okay.
Thank you. Dr. Gora, could you please share your screen just to check everything is all right?
Sure.
Your internet is working well or not?
Goral also.
Break to welcome you back, and I hope you all had something to eat and to drink, that you're ready for the second half. I will just share the second half program so you can see it. And here we are on our second half of the day. We will have semen analysis and improving its quality by different preparation methods. And we have vitrification, fertility preservation. So that's one mistake here, vitrification. Okay, so sharing and invite my dear colleague and friend, Professor Ali Salmasi, to please take the screen and start to address us for the second part of the afternoon. Ali, you went away again from screen sharing?
Yes, yes, yes. I had problem with computer.
Okay. Now you're there.
Okay.
Yes. Just go to your first. Yes.
Okay. Greetings from here. Good evening, everybody. My name is Professor Salmasi. I was former director from IVF Laboratory and Scientific Research Women Hospital Kiel in Department of Professor Mettler, University of Kiel. Since 2008, I am certified as senior clinical embryologist by ESHRE, and since 2015, I am senior advisor. This is our laboratory with Professor Metre together. My subject is today about semen analysis and proving its quality by different preparation methods. First of all, I would recommend some literature, books, Male Infertility or Atlas of Human Sperm, and basic laboratory embryology, and especially from WHO laboratory manual for the examination and processing human semen. We need the sperm preparation for IUI, IVF, ICSI, and TSA. The equipment is necessary for sperm analysis in ERT laboratory is phase contrast microscope. This must be a total magnification 400 to 1000. It's combination of ocular lens 10 times and objective 40, better take to 63, and you reveal the sperm analysis, agglutination, aggregation, and round cells. It is better to have a microscope connected with camera and monitor to get better resolution. You need for assessment of sperm number counting chamber, usually we take a marker, or you can take counting cell vision. This is disposable. We need, or better is to have a counter. This counter, you can count the classified EBCD and convert it in percent. And it is very, very easy to have it.
Dr. Ali, can you speak a little loudly? We can't hear you properly. Can you speak loudly, please?
I speak
a little loud.
Okay, I try to speak not normal. So we need also desk centrifuge, collection of semen and analyzers. 2 sperm analyzers should be accomplished in the distance of 4 to 12 weeks. Collect after 3-5 days of sexual abstinence. and take a sterile container labeled with the man's name and identification number. Just a moment. I have to hear. I can't see you. Ah, oh, okay. This is this container. Maybe you have to take it, a name of patient's date and time of delivery. So document date and time of collection, place it in incubator while the semen liquefaction. Microscopic analysis you have to do between 30 and 60 minutes. After semen liquefaction, look appearance of semen. Measure the volume. Look for semen viscosity and measure semen pH. Appearance of semens, you see here 4 different semens. This one is normal color, gray and opal. This one is hemospermia, had blood test and is acute infection. And this one is pyospermia. It's usually 12 and occurrence of pus. After liquefaction, homogenize the samples with a pipette, sucks in two and press it, and it's homogenized. Sometimes if you aspirate the semen into pipette, sample drips from pipette is normal. Sometimes it's viscous and drop forms a cream. What to do if ejaculate are very viscous? You have to reduce the viscosity. You can do mechanical or enzymatic. Dilute your sample, mix it with sperm preparation medium, usually, and mix it, usually don't force it. Sucks your sample in a syringe and try to take a narrow gauge needle and press it. Usually works very good. If not, you have to treat enzymatic desiccation. Dilute the semen with bromelain and stir it 37 degrees 10 minutes. So microscopic investigation of semen between 30 and 60 minutes. You look for assessment of sperm number, motility, morphology, vitality, aggregation or agglutination, and round cells. The standard procedures of normal sperm according to WHO criteria are volume must be higher than 1.5 milliliter, pH above 7.2. Sperm concentration higher than 15 millions per milliliter or 39 total. Motility higher than 32%. Morphology 4%. Viable sperm 58%. And 1 million lower leukocytes. For counting as the sperm, you need a chamber. Usually I take the marker, drop 5 microliter and cover it and look under microscope is pure. First, I count 10 fills in this direction and 10 in this another direction. And you have the mean level given into millions. Gradient of sperm motility according to WHO. E and B is now together. E is sterile, very progressive motile sperm, and usually they are sterile line. And grade B is no linear, usually is curved and crooked motion. Grade C is swimming small in its circle, and grade is immotile. I will show you now a sequence of film. Maybe we can then see together. So these samples you see is a very low concentration of sperm, and usually, and you can find motility E, only maybe C, like this one, and over here. The next one is also very low concentration. You can see abnormality in neck or the tails, and these are oligoastenoteratodes of grade maybe 2 or 3. So embryologist is every time happy to get these samples. You can see here A, E, this is B, and a lot of sperm, high concentration and high motility, but I think the morphology is not so much. Maybe this will be a teratod sperm. So sperm abnormality according WHO, you have classified as oligospermy, astenotospermy, teratospermy, cryptospermy, or necrotospermy. You have then document all the protocols after spermiogram or after treatment. Date, patient's name, birthday, time sperm delivery is important, abstinence day, medication, sperm analysis after 35 minutes, and look consistent, is normal, agglutination, we have no. Then it started with morphology and motility analysis according to WHO. Native sperm, you can see here in the table, the volume, concentration, E and B together is about 22%. C, D is 69, and normal formation is 1. After treatment, you have volume, concentration 11 million, E and B increase of 30, and you have C is low, and D is 58, and normal is 2. You write a report to the doctors, sample treatment, we did wash and centrifugation. After treatment with wash and centrifugation, there were enough E and B motile sperm for XC. Fertility restriction, yes. Assessment, oligoastenoteratospermy. This is for sample number 2. So, sperm morphology, differentiation of semen morphology. Usually I take test simplets. This is pre-stained slides and presence of 2 dyes. It seems like this one. You can see it maybe. So I drop 5 microliter ejaculate and cover it and look on the microscope. Sperm will be in pupil. You can find anomalies in head, acrosome, post-acrosome, neck, and tails. You can see here is normal one, acrosome, post-acrosome, and tails. Maybe here is some abnormal. Big post-acrosome, here is like pinhead. As example, I will show you some example from Atlas Human Sperm Morphology Evaluation. This is a normal sperm. You see acrosome, post-acrosome, tail, and the neck. You see here some example for abnormal. You see here bent mid-piece, over thick mid-piece, or you see coiled tails or double tails. There's a lot of abnormalities in sperm. Assessment of sperm vitality, assessing the membrane integrity. You can tell it by Vita scan or hyposmotic swollen text and other tests also. The easy one is the vitality test with Vita scan. You have SOZ necrosis dying. A live sperm has intact membrane and will not die, and it is white. And dead one, this membrane is defect and will be open for the red. You can also take hyposmotic swelling text. You incubate your sperms with diluted solution, HO, and usually is fructose, and you see after 10 minutes, 5 minutes, sperms with intact membrane start to swell. Now, sperm preparation for ERT. Why must sperm be separated from seminal plasma? This is because seminal plasma is cytotoxic, contain bacteria, prostaglandins, and if you select, then you have selected very good sperm from the bad one. Therefore, we have to wash the sperm. And first, you allow the semen to liquefy at 37 degrees for 30 minutes. Specific sperm preparation technique are washing and centrifugation, direct swim up technique, normal swim up, density gradient, centrifugation, and maybe Cefadex current glass filtration. I will show you some of this example. The choice of sperm preparation technique is dictated by the nature of semen samples. So, culture medium I use for sperm preparation. For spermiogram, I take sperm air. This is only just to warm to 37 degrees. It is not necessary for fumigation, and CO2 is not required. Sperm active from Gynemed I take for sperm washing, swim up, density gradient, testicular thesis, and it is with beepers to stabilize pH outside of incubator. Simple washing technique, wash and centrifuge. The semen samples, if they are good quality, often you use for IUI. You mix the same semen with sperm preparation medium, centrifuge at 1800 for 10 minutes, remove supernated, and recess the sperm to pellet and use it. You see a relation between total number of sperm concentration and pregnancy rate. The pregnancy rate increases with increasing number of sperm and reach a maximum about 18% at less concentration of sperm, maybe 20, 30 millions. Swim up technique. You have direct swim up. This can be performed by either by layering sperm with by layering sperm preparation over the liquid semen, or the layering liquid semen under the sperm preparation. You can see it, or you cannot. Now, maybe this is the sperm above, and this is our culture medium. You let it and sperm then swim up, and you can take it and use. Normal swim up is I usually sperm active. You take your sperm, ejaculate, and dilute it with culture medium and mix it very carefully. Centrifuge at 1800 for 10 minutes. Remove supernated And in the pens, you will do ICSI, IVF, IUI, layer with culture video. Usually, if you do ICSI, you have very bad quality of sperm intake, then about 200 microliter for overlay. If you have IVF intake for the IUI, 1 milliliter, and put in incubator, the good sperm will swim up. After 1 hour, you can collect it and use it. Method, very good method is density gradient centrifugation. This separates the cells based on their density. Usually mature sperm from normal, you can select from immature, deep cells, cell fragments, leukocytes. Advances increased number of vital sperm than by swim-up method. Disadvantages need more experience, more complex methods to swim up. You see here the gradient technique. Maybe I can show you. I try it to show you. Oh, not possible. Okay. Can I show that? Can you see me?
Yes, we can see you. You just put in
Okay.
front of the camera.
Just show it.
And
Yes,
where is,
I want to show something.
yeah. Just put
It's
in the
not
front of the
possible, no problem.
front of the camera. Just put in front of the camera.
Just hold it up because we can see you.
Ah, you can see me?
Yes, we can.
Really? I cannot see myself.
But we can see it.
Okay.
So go ahead. Show it to us.
Okay. If you see me, it is okay. So take first 80%. This is low buffer. And carefully put in a tube waveform. Can you see that?
We can see it well.
Okay. Now you take the 40%.
Try to put in the front of the camera. You
I will come back. I have to bring my sample. Okay?
Yeah.
Sorry. Look.
Now you overlay it.
Usually I take glass pipette. Okay, now we have 40%. And then I take the sperm. Oh. Okay. It was a little rapid. You can see.
Yes.
Oh, yes. Yeah. You have 80%, 40%, and the sperm. Okay. Now I will good. Then centrifuge it at 1,800 for 20 minutes. Then you will get pellet. Then go with a glass pipette into pellet and suck the pellet and put in a new tube and mix it with culture medium. Okay. How can I see you? You can see me well, okay?
Yeah, you need to share your screen again.
Share screen.
Everything okay?
Yeah, share your screen again.
I try to find it.
Press the green button, share screen. Then you come back to.
It's not here. Maybe I have to go out. So,
Go back to your lecture. The green button. We know that now you're centrifuging, and then you have the pellet.
You can see now?
Yes, go downward to its slide where you stopped. Yes.
Okay. Okay. Resuspense the pellet in this sperm preparation medium. This was this one.
Yes.
And centrifuge it 1800 for 6 minutes. Remove the supernated and pellet layer or resuspense in culture medium. It depends, you will IVF or XC. If you XC, 200 microliter, IUI, IVF, 1 milliliter, and assess the count of motility. So sometimes we have autospermy. This is no sperm in ejaculate or necrotospermy. Extraction of sperm from PZ or MESA. Sperm extraction methods from PISA and MESA, you can do enzymatic method, you can use mechanical method. For enzymatic, you cut tissues, biopsy in small pieces, and incubate with collagenase for about 2 hours at 37 degrees. And vortex it is every 30 minutes, centrifuge it 100 G, maybe 100,000 to 1,200 rounds per minute for 10 minutes and use the pellet. Mechanical method use and press with needles. Usually we have frozen tissues. We have to thaw them. First we thaw the tissues at room temperature, wash 2 times, cut tissue biopsy in small pieces, then put the needles, you can see here needles, 2 times, on tissue and push and pull apart the needles. Then this homogenide, you put in a tube and keep in incubator for 2-3 hours. Before starting with ICSI, centrifuge it at 1,200 rounds per minute and 12 minutes. Aspirate supernated and pellet resuspense and gently or layer with sperm preparation medium to use it. Now I will give you some tips and tricks at specific sperm preparation technique. It is mainly in labors very important what I will do, what I have to do. For spermiogram, always we have homogenized equalized semen. Assess the sperm number and other parameters. Then, when a sperm number is higher than 5 million, do swim up or density gradient. If it is lower than 1 million per milliliter, then take wash and centrifuge. And every time assay sperm parameter after 60 minutes and 4 hours. This is for spermiogram. If you have IVF or IUI, lower, higher than 50 million, take swim up or density gradient. If it is lower, wash and centrifuge. Assay sperm parameter after 60 minutes, 4 hours, and day after 24 hours. For long time motility, it's important for IVF. Special case for ICSI. If you have more than 1 million sperm million, swim up or density gradient. If it is lower than 1 million, wash and centrifuge. Sometimes you have only in ICSI phase 0 up to 1 sperm per field of your view. So, ejaculate centrifuge 10 minutes at 1,800 rounds per minute. Pellet resuspense only 20 macroliter sperm preparation. Usually, mainly is to recommend ask for a second sample. I have very good results with second samples. So now what is a good sperm quality? This is a question. According to WH, this parameter means you have good sperm, but we have no information about sperm DNA integrity. DNA integrity is DNA damage, single-stranded or double-stranded. This causes apoptosis. Apoptosis can come later to abortion, and hence, this apoptosis reaction and hence cell death. DNA fragmentation is defined as EFI, fragmented sperm divided complete sperm multiplied with 100. If it is lower than 15, you have very good fertilization potential for IVF-IU. If it is higher than 30, the fertilization potential is very poor. Important is in our laboratory separation and immediately use of vital sperm. Be free from DNA fragmentations for XC. What to do? You use that surface marker you need. Techniques is hyposmotic swelling test, sperm selection by magnetic activated cell sorting, sperm selection by hyaluronic acid binding, or the sperm slow. So sperm selection by magnetic activated cell sorting. This is selection non-apoptotic spermatozoa from apoptotic. Usually apoptotic cells, sperms have on the surface phosphatidyl serine, PS. We have annexin 5, it is a protein that ability to bind to PS. Annexin 5 were coated with microbeads and mixed with sperm and fill in a magnetic cell sorting column. The beads retained apoptotic sperms, whereas the non-apoptotic sperm flow through the column. This is the column you can see. I hope so. Magnetic, fill in, and unit and magnetic activity. And here is the beads.
Okay.
So, system is an efficient method and select functional sperm and improve pregnancy rate. You can see according to this table, raw sperm sample is 22% has PS. After, you see how it's important density gradient, reduce of 13. If you do both of this method, density gradients and max, you have only 7% of fragmentation, DNA fragmentation. So next one is sperm selection by hyaluronic acid binding. The major sperm can bind to hyaluronic acid because it has a receptor for this hyaluronic acid and move strong the tail without forwards to moving, only tail. The major spermatozoa not bind to HA and swim free forwards. This correlates with maturity of sperm, morphology, high DNA integrity, and reduced chromosomal aneuploidy. This is a pixie dishes. I can try to show you, maybe it is not easy. You have here 3 times hyaluronate spot drop. You overlay this with sperm propagation medium and overlay with oil and insert sperm into drops and incubate for 5 minutes at room temperature. Maybe I can show you in a video.
Okay.
You will be then happy. Maybe. No problem. So, okay.
Thank you. We could see it. Yes.
Oh, what is happening? Oh, man. Okay. Yeah.
Okay, Ali, you have 5 minutes to go, please.
I am just finished. What is happening?
Yes, because we haven't one more speaker, so please, 5 minutes, you round up.
Okay. I don't know why. Now maybe, yes. Okay, pre-incubated with culture medium,
Yeah.
and now cover with earth. And now sperm, that's a sperm, and incubate it about 10 minutes. After 10 minutes, you will see the sperm is already binded, is mature. You can select it and put your oocytes into and carry out ICSI. Okay, the next minute is sperm selection for ICSI. By sperm is low. You have ICSI dishes. You have a drop of sperm propagation medium. Sperm is low, 1 drop, and 1 drop to collect for sperm. Sperm is low, and these drops are for oocytes covered with earth, and bring your sperm in culture medium and bind these drops together. The sperm will then move to sperm is low, is hyaluronic acid, and bind it, and you can to select them, collect them, and carry out your ICSI. Thank you very much for your kind attention.
Thank you very much, Ali. And
Thank
now
you.
stop sharing the screen. We have several questions. So the first question is, which method is to select the right sperm from Chigwe or Gwili? Which method is the best? BC, all look complex.
Because all look complex.
Is it the swim up or the density gradient? I mean, you explained that for the bad sperm, we use the swim up, and for the better one, we would use the density gradient. But can you answer the question?
Yes, density gradient is the better method, but
Okay.
it is not easy.
Dr. Neher
But I
wants,
showed you.
should DNA fragmentation index be done for all oligospermias?
Usually, yes. If density gradient I showed you reduce the fragmentation, but slim up not. If you additional do like hyaluron binding assay or magnetic system, then will be more reduced.
Can you please show your first slides again? Please tell us some clinically helping books or guidelines. You showed in the beginning, you showed the ESHRE guidelines and the book. So if you
Oh, yes,
you go into your presentation again, share screen,
yes,
start the presentation, so then the doctors can take a picture of the book's name and
of course, of course. This one?
yes, we can see. So it's a WH laboratory manual for the examination of processing of human sperm. So that
I
is,
have problem with sunshine. Okay,
we
I
can
have
see
too much.
that one is a very good book.
Mm.
Yes,
So two,
you can find it in internet. It is not to buy. You can download it.
and then you had two other books on the slide, I think a little bit down. Go,
This
go,
one?
go 2 or 3 pictures up. Oh yeah, there are the books, yes. Human sperm morphology evaluation.
This, yes, this one and this.
Yes, leave that a moment. A practical guide to basic laboratory andrology. That is a
Yes,
very to be recommended.
yes, yes. I have
And-
written a reference for this.
And how about that book, male infertility? Can you show that one again also? The red, yellow one slide up.
Red, yellow one.
One slide up.
This one?
Yes.
Diagnosis and treatment by Tinus Krüger and Sergio Oeninger. These are our South African colleagues, good friend
Yes.
of mine, right? And they've written a very nice book on that. And we also have a participant for South Africa, so that is very good reference point.
Thank
Thank
you, thank you.
Ali, stop sharing. Now the next question for you is best preparation technique for asthenospermia for IUI. Minu, you are bringing that in your lecture, no?
Yeah.
Or Ali, do you want to answer it? Best preparation technique for asthenospermia for IUI.
Goral, you want to answer this?
Coral, can you answer?
Go for density gradient, right?
Density gradient would be the best method, yes.
Very low
Depends on, yes, yes.
density.
Any kind of abnormal form parameter, you have to do density gradient.
Then Dr. Neha wants to know only prolonged liquefaction time with other normal semen parameters. Do such patients need IUI? When they have a prolonged liquefaction time, other parameters are normal. Would you advise these patients to do IUI? Clinical question, really.
You can,
Yeah.
what kind of infection they have?
But if the liquefaction is slow, is that a sign that they would need IUI?
It depends on the sperm concentration. How is
Right.
the concentration?
But,
If not, you can do wash and centrifuge.
what is the specific sperm preparation method for semen from HIV positive males? How would you treat the semen for HIV positive male?
Yes, yes. Maybe I show in my lecture.
Pardon?
I can show this in my lectures.
He will
Can
show
go-
it in his next lecture, Lilo.
I see. Okay, good. Then would you do, Gaurav, do you want to comment on that?
Yeah, so basically we need a multi-layered discontinuous density gradient method for HIV positive males.
Is there a major cost difference between density gradient and swim up?
Or for, I will show something, Lilo.
Yes, okay.
This one is for patients. Can you see it?
Yes.
This one is for patient with infection, AIDS like this one, with this tube, special, or density gradient. If you like, I can show some picture in my lecture. Can I go into?
And we have no time, but that's fine that you showed it. That's good. So,
Okay, the name is here.
Pluralcelt. We can see it. Show it again. Show the name again.
So name is
Show it again.
Proloncet.
Prol.
Okay, maybe so.
Third.
Can you see?
We can see. Good.
Okay, this is a special one.
Is there a major cost difference between density gradient and swim up? Density gradient is a little bit more expensive, of course. You have to have the culture media.
Yes, not so much. Yes, it is, yes.
Even if abstinence is more than 2 to 3 weeks,
Yes.
is that okay, or should the man have intercourse and come after 3 days?
No, it is okay, but maybe it is the concentration of sperm high and ejaculate is a little turbid.
So,
more gray.
okay, Dr. Supriya wants to know, sir, a male with HBS AG positive after fertility, affect fertility. What is HBS AG? What is that in minute?
Hepatitis B. If the man is hepatitis B antigen positive, will that affect the fertility?
What method for subfertility is advisable? Who can answer that question?
Goral, can you answer?
Yeah, I don't think HbS-Ag status affects fertility in males. I have not seen. I have seen normal semen parameters with HbS-Ag positive males. And what method for subfertility is advisable? I did not understand this question.
So if the male is HbS-Ag positive and he has oligospermia, which method will you use, and I mean, how will you go ahead?
Again, with HbS-Ag positive, it has to be a multi-layered density gradient method, because we want to, remove the viruses as much as possible.
Khadijah's question we have answered.
Must be very. Can use this one also.
The last question of the Rucha is, what are the indications for MACS test?
So MAX is not a test, it is a sperm separation technique. And generally MAX is used when you have, a history of, say you have a report of high DNA fragmentation index. MAX is going to give you more functionally normal sperm.
Good. So it's okay. So then, madam, what do you mean by multi-layered gradient method? So in Professor Salmasi showed us a double-layered density gradient method. So in multi-layered for HIV positive males and HbS-Ag positive, we can have 3 or 4 different concentration of the gradient. That is the difference. Okay, thank you very much for we had many questions. Ali, thank you very much for the presentation. And now we ask our friend Goral Gandhi, and it's my big pleasure to say the name Gandhi with us because we're in India. The family, such a caring and meaningful name. Yes. You now as a teacher, and please share the screen. Yes, I do. Why can't I see my presentation here? It is open.
You have to share your screen. You have not yet shared your screen.
Yes, I'm trying to share it, Meenu, but I can't see my presentation to share.
Ali has closed his stop sharing, right?
Yeah, now we can see it.
Yeah, now we can see.
Okay. Okay. So I'll go in the full screen mode.
And also in the end, if you can explain the multi-layered, that will be nice. That multi-layered.
I'll do that. I'll do that.
Thank you.
I'm trying to get this.
Go to the presentation mode.
Yeah.
That bigger icon down.
Okay, yes. Okay.
Good. Perfect.
Yes. So, hello everybody, and thank you for your patience to be here till the end. And today I'm going to talk about role of vitrification in IVF, current perspectives. I presume that most of the attendees are clinicians, so I have tried to keep my lecture with with more of applications of IVF rather than making it more technical, because vitrification is a highly advanced embryological procedure. So I'm not going to go into the actual technical details of vitrification here, but rather I want to focus on the role of vitrification. So as all of us are aware, vitrification has certainly become a mainstream technique in all IVF centers in the last decade. Most of our embryo transfers are becoming frozen embryo transfers. There are many reasons for this. Professor Meckler, Dr. Agarwal, they have both mentioned reasons for frozen embryo transfers. We may be wanting better embryo and endometrium synchrony. We may be wanting to freeze all embryos to prevent ovarian hyperstimulation syndrome. Sometimes we plan frozen embryo transfers for a better coordination of our donor egg IVF program. Sometimes it is just plain convenience of the logistical and planning convenience by which we do a frozen embryo transfer. And of course, fertility preservation is a very big role of fertility vitrification. But whatever is the reason, I think the game changer for us for moving towards more and more frozen embryo transfer today has been this wonderful technique called vitrification. With vitrification, now we have embryo survival rate and even oocyte survival rates of 100%. We have all the embryos surviving, we have all the oocytes surviving. And because as vitrification procedures have improved its success profiles, we are seeing more and more transfers becoming frozen embryo transfers. So today I want to focus on these four aspects where vitrification is playing a big role in the way we practice IVF today. So first, let us look at the role of vitrification as a way to prevent multiple pregnancies. Now, as all of us know, all of you are gynecologists, everybody knows the complications of multiple pregnancies, the complications that the children can have because of multiple pregnancies. So we have multiple pregnancies because we transfer more embryos. Even today in India, there are many labs that transfer up to 3 or 4 embryos in a single attempt. So the major drawback of transferring more embryo is multiple pregnancy. But when we transfer more embryos, there is also embryo wastage. And I'm going to come to this a little later. So today we are in 2020 and we need to reassess what we call a successful IVF outcome. Twins and triplets that land up in the NICU for months and who may end up with lifelong complications perhaps is no longer considered as a successful IVF outcome. Our aim is to maximize the chances for our patients to deliver a single live healthy baby. Today in 2020, this is how we should be assessing success of our IVF treatments. So how do we reduce multiple pregnancy? Obviously, the answer is to reduce the number of embryos that we transfer. So that brings us to the question, why do we transfer so many embryos? We are creating a lot of embryos because of ovarian stimulation. We have these 5 to 6 beautiful embryos growing in our culture dish. And then why do we transfer more embryos when we know that we have all these complications with multiple pregnancies? What I think it is a practice based on pregnancy rates for each clinic. Everybody knows what are their pregnancy rates and they want to maintain that. And it is expectations of the clinics and the laboratories and expectations of the patients. All the clinics want their success rates to remain very high. And I think perhaps our focus sometimes is more on success over safety. And of course, it also depends on the available cryopreservation technology. Say if we are not very confident about the cryopreservation or vitrification program that we have available in our laboratory, and if we have 3 embryos growing in the culture dish, we may think that if I, freeze 2 embryos out of this, I may not get all the 2 embryos back. And then let me just transfer the 3 back and see what happens. But if you have a wonderful vitrification program where you're very confident about the embryo survival, then you can definitely not transfer so many embryos. And coming to embryo wastage. So when we transfer more embryos, say we have 3 embryos, and we are going to transfer these 3 embryos in one patient in the same cycle. Now, say for some reason, the endometrium in this particular cycle is not good enough, or on that particular day, there is some problem and the embryo transfer process does not go as well as we have anticipated. What are we doing? Perhaps we have wasted all the 3 embryos. The patient may come negative and we have wasted all the 3 embryos. Another scenario, what if, everything is perfect, endometrium is very good, embryo transfer process is very, very smooth, then what happens? The patient may get pregnant and she may end up with a high order multiple pregnancy, like twins or triplets. And we may have to go for a fetal reduction. And again, we are wasting embryos. So what can we do? Instead of transferring all the 3 embryos in one attempt, we can transfer one single embryo. We can transfer 1 embryo in the first attempt and freeze the 2 for the next attempt. So if the first attempt fails, we can review the whole process. We can see what we want to change as far as the endometrial preparation is concerned, and we can plan a frozen embryo transfer. Now, there are many studies, and I want to show this particular study where we have, with single embryo transfer, they've reported live birth rate of 26% and with double embryo transfer, a live birth rate of 42%. But if you see multiple pregnancy rates with single embryo transfer, of course, it is negligible. And with double embryo transfer, we have a multiple pregnancy rate of 32%. Now, the same authors have further shown that if they do 2 single embryo transfers, one fresh and one frozen, then the cumulative pregnancy rate with 2 embryo transfers, 2 single embryo transfers is 38%. And the multiple pregnancy rate is again almost negligible with this approach where we are transferring 1 embryo at a time. So ultimately, the patient is going to get pregnant and is not going to end up with a multiple pregnancy. What about transferring more than 2 embryos? This is a comparison between 2 embryos, transferring 2 embryos and 3 embryos. And as you can see, there is not really any difference in the live birth rate, but the multiple pregnancy rate with transferring 3 embryos is very, very high. So what are we to do? Now, patients today are very intelligent, but they are not scientists. And they rely on, most of the times, they rely on us to take decisions for them. So we need to explain this concept of cumulative pregnancy rate to our patients. And we also need to offer them alternatives to transferring multiple embryos. We need to offer them blastocyst culture. We must learn to culture our embryos up to blastocyst so that we can very confidently give them embryo selection and transfer just one single good embryo. And in today's day, we can have pre-implantation genetic testing and transfer one euploid embryo. And of course, we must offer them a very, very reliable cryopreservation technology so that we can safely preserve the embryos for future attempts. Now, vitrification, let us look at how it helps in preventing ovarian hyperstimulation syndrome. We know that ovarian hyperstimulation syndrome is a potentially life-threatening iatrogenic complication of IVF. a variety of preventive strategies have been described, but none of them have shown consistent efficacy. Cycle cancellation is, of course, the safest approach, but it is extremely frustrating as well as costly for the patient. And there is no guarantee that, stimulating the patient again, she may again land up with ovarian hyperstimulation syndrome. So instead, we can offer them elective cryopreservation of all the created embryos and postpone the embryo transfer, and we can plan the embryo transfer in the next cycle. So this works very, very well. There are many studies showing the application of vitrification to control ovarian hyperstimulation syndrome. Another wonderful application of vitrification is in minimal stimulation. Now, gentle ovarian stimulation protocols, known as mini IVF or minimal stimulation IVF, have been thought to produce less eggs, but these eggs are of much higher quality. Now, with all pre-implantation genetic testing studies, we know that the embryos produced with milder stimulation protocols, we have more euploid embryos. So it is we get higher quality embryos, and these protocols are easier on the patient. Many studies have evaluated the efficacy of this mild, low-cost, minimal stimulation protocols paired with vitrification. And routine IVF is slowly being challenged by simple and more cost-effective methods like natural cycle IVF, minimal stimulation IVF, and IVF light. So this is a study from John Zhang. John Zhang is the pioneer or the father of minimal stimulation IVF. And this is a data from his lab. It is a retrospective data analysis of patients who underwent mild ovarian stimulation protocols. All the embryos were vitrified at the blastocyst stage, and the frozen embryos were thawed and transferred in subsequent cycles. So if you see that they got very, very good pregnancy rates in all the groups. Under the age of 35, they had a pregnancy rate of 54%, and even over the age of 40, in the age of 41, 42, they had a pregnancy rate of 21% with mild stimulation protocols. Now, again, this is a very important paper which I want to show you from St. John Zhang's lab, but it is showing fresh as well as frozen embryo transfers with mild stimulation protocols. And a total of 1,500 single embryo transfers are there. And if you see the results, with frozen embryo transfers, the clinical pregnancy rate that was achieved is 41% versus only 20% with fresh embryo transfer. And so this paper very clearly shows us the benefit of frozen embryo transfers in minimal stimulation protocols, because in minimal stimulation protocol, we are giving clomiphene citrate for the first 5 days, and the endometrium is not going to be optimal. So minimal stimulation protocols are actually not thinkable without a very robust vitrification program. This is our own research from our lab with IVF Lite as a new strategy for managing poor ovarian responders. And IVF Lite is minimal stimulation IVF, and we create embryos, we culture them up to blastocysts, and we vitrify them. And this way we accumulate embryos till we have about 4 to 5 good grade embryos, and then we plan a remote embryo transfer. And for this particular poor ovarian responders, our inclusion criteria was less than 44 years of age, and at least one previous controlled ovarian stimulation cycle with poor response defined as less than 4 mature oocytes. And when we compared the results with conventional IVF versus IVF Lite in poor responders, we got the clinical pregnancy rate per embryo transfer was 27% in IVF light group, whereas 15% in conventional IVF. But when you see clinical pregnancy rate per patient, we had 48% patient achieving pregnancy with IVF light in this difficult group of patients versus 24% with conventional IVF. So the IVF light protocols requires a very robust and efficient method for embryo cryopreservation, like very advanced cryotic vitrification, because of the negative impact of clomiphene citrate on endometrium. And cryopreserved embryo transfers with this protocol have yielded much higher pregnancy rates than fresh transfers. So minimal stimulation IVF protocols are absolutely unthinkable without a robust and efficient vitrification program in your lab. Remember, these are the patients where we are creating just one or two embryos. These are very precious embryos for the patients. So you have to have a vitrification program that is going to give you 100% survival rate. You cannot afford to lose a single embryo for this group of patients. Another very important application is fertility preservation. There are many, many reasons why women need fertility preservation. First and foremost, cancer patients. We know that chemotherapy and other surgical interventions to treat cancers, they are all going to have negative impact on the reproductive potential. And oocyte vitrification, ovarian tissue vitrification should be offered to these patients. I think you have lectures on fertility preservation, so I'm not going to go into much detail. Age-related infertility, social egg freezing is another very, very important application. Dr. Meenu has already mentioned, and I think you have a lecture on social egg freezing and diminishing ovarian reserve. So again, I'm not going to go into much detail, but women have to remember that there is the biological clock for women is ticking very, very fast. Women have just about 15 years within which they can reproduce. So now we have very efficient egg freezing or oocyte freezing technologies available, which will give us 100% survival rate. So I think women must be offered this option of preserving their fertility so that the time frame within which they can reproduce can be extended. So this is the significance of vitrification in ART practice, and it has greatly changed the way we practice IVF today. It has helped us greatly to move towards single embryo transfer. It is only with the confidence that we are saving these embryos without any harm to them for future attempts that we are so confidently doing single embryo transfers. So since vitrification is so important, I'm just going to tell you that what should we look when we do the actual vitrification process. Our aim in vitrification is to keep the embryos and oocytes safe without any damage. We are suspending all metabolic activities when we vitrify them, and when we thaw or warm these embryos or oocytes, we want that fertility potential to be completely preserved as it is without any trauma to the cell until we are able to complete the patient's family with these gametes. So how do we achieve this? We have to use a very well-established protocol. A well-established protocol means it has to be very reliable. We must get consistently, repeatedly, very high survival rates. It should be universal. That means that constant high survival rates must be achieved by all laboratories and not just few. The protocol has to be universally good. Before vitrification, we were doing slow freezing. Now, slow freezing used to work very well in certain hands, but in many other labs, it never worked very well. In my own lab, in my hands, slow freezing did not work very well. I was never happy with slow freezing. And with vitrification, it is a very universal technique. World over, everybody is achieving almost 100% survival rate. And of course, it has to be a very safe method. So only when a protocol or technique is reliable, universal, and safe, it is going to become in as a clinical technique, and we call it an established protocol. There are mainly four major steps in vitrification. First, we are going to add cryoprotectants because we need to protect our gametes from the cryo injuries. Then we are cooling the cells to minus 196 degrees and we are storing it. Then the next step is warming. Whenever we need to use, we need to warm the cells. We need to bring them back to life and we need to remove all the cryoprotectants that we have added from these cells. Now, what are the factors that can influence efficient vitrification? What are the factors that will influence success of the vitrification process? First and foremost, the protocol that you are going to use, the cryoprotectants that are added. Remember that in vitrification, very high concentration of cryoprotectants are being used. In fact, the concentration of cryoprotectants used in vitrification solutions is almost 3 to 4 times than what we were using for slow freezing. So this is something that to remember when you're actually using these techniques in the lab. I think all embryologists need to be aware that vitrification solutions have very high concentrations of cryoprotectants and they must be aware of how to handle them. High cooling rate and even higher warming rate is very, very essential for success of vitrification. Type of carrier device, the temperature of vitrification solution that you're going to use at exposure, the duration of exposure to the cryoprotectant, the volume of the vitrification solution, and finally, last but not the least, the experience of the operator. All these factors are going to affect the outcome. Very briefly, I know none of you are embryologists who are going to do these techniques, but very briefly, I'm going to show you some tips to optimize, some practical tips for using high concentration of cryoprotectant. Remember that toxicity of cryoprotectants is correlated to its concentration and the time of exposure as well as the temperature at which we are going to expose. The fast entrance and the degree of toxicity of the cryoprotectant can be influenced by temperature. And it has been shown that using cryoprotectants at room temperature of 22 to 25 degrees, especially when the cryoprotectants contain DMSO, it is shown that when it is used at lower temperature, the toxicity is less than when it is used at 37 degrees. This is a very, very important thing to remember. I cannot emphasize it enough because in IVF as embryologists, we are very paranoid about 37 degrees. We keep measuring our incubators, our workstations, everything that they are maintaining perfect 37 degrees. But when we are doing vitrification and warming processes, we want our workstations to be at room temperature. We turn off the heating while doing these processes. Because at 37 degrees, the rate at which the cryoprotectants will enter the gametes is going to be very high and the toxicity of cryoprotectants is going to increase. The time again. So because of the high toxicity of cryoprotectants, it is important to watch the duration of exposure to the final cryoprotectant very carefully. And that is why two-step equilibration is important. So we have first step is equilibration step, where we have the equilibration solution, which is a much lower cryoprotectant solution. So you equilibrate the cells for sufficient time for complete removal of intracellular water. In vitrification, it avoids ice crystal formation. So we want complete dehydration of the cell. So in equilibration solution, we are ensuring complete removal of intracellular water. And this is followed by a very short, just about 60 seconds of incubation in the final vitrification solution, which contains very high cryoprotectant solution concentration. And then you just load it in your device and you plunge it into liquid nitrogen very, very fast. So the last step should be done within 60 to 90 seconds. Exposing to VS, loading and plunging into liquid nitrogen should be done within 60 to 90 seconds. Some practical tips while loading the carrier. As I said earlier, vitrification is a very skill-oriented process. So choose a method that is easy. Choose a method that is not very complicated. Easier your protocol, it means less room for errors. So choose an easy protocol. If you're vitrifying more than one oocyte or embryo on a device, then it is preferable to make multiple small drops with one embryo or oocyte in each drop instead of making one large drop with more embryos. So instead of making a huge drop with your 4 oocytes, what we recommend is make multiple small drops. So some of these drops will have oocytes, some of these drops will not have. So don't worry about the drops that do not have oocytes. Just go on making small drops till all your 4 oocytes come on your device. So this way, each oocyte is going to be in minimal volume, and this is a much better method rather than putting all of them together and then dragging the media. Don't do that. We do not drag, do not remove any excess media, because when you put more media and then you remove all the excess media with your pipette, there are very high chances of injuries to the zona. So we never drag the excess media, just make multiple small drops with one oocyte. This is again a very important thing. The minute you change this, I have seen that the minute this is changed, the loading technique, the survival rates improve. Warming rate. Now it is shown that majority of injuries and damage during craft preservation happens due to ice crystal formation. We know that. And during warming, there are very high chances of ice crystal formation. And high warming rates prevent the vitreous water present in cells from crystallization at the time of warming. So high warming rates are even more crucial to survival than high cooling rates. And according to me, the most crucial procedure factor in whole of your vitrification and homing process that is going to affect survival is this first step of warming. So this has to be performed with utmost efficiency. Greatest possible precautions need to be taken to ensure that very high warming rates are achieved. How do we ensure this? So we put the first, remember I've told you that we do the procedure at room temperature. All the solutions of vitrification we bring to room temperature, but the first thawing solution, when we are thawing, the first solution is called the thawing solution. That is kept at 37 degrees for at least 3 to 4 hours so that it is at 37 degrees. And even the plate in which we are going to thaw the embryos is kept at 37 degrees. And then we bring, take out your straw, keep everything absolutely ready. And then you bring your embryo from minus 196 degrees to 37 degrees in a split second. Very, very fast. You make a hand movement like this, which is parallel to your plate, parallel to your stage. And don't make a circular movement like this, which is going to increase the exposure to air. These are very, very small things, but they add up and they really add to your survival rates. So, I feel that this is one rate limiting step, and this step needs to be performed very efficiently. And then the protocol says, most of the protocols say that you have to keep the device in your thawing solution for 1 minute and do not manipulate the oocyte or the embryo during this 1 minute. The thawing solution is very high osmolality and again very high chances of zona injuries in thawing solution. So do not manipulate your oocytes and embryos in this 1 minute. Now there are mainly 2 types of system of vitrifications. Open system vitrification, where the cells, where we load the oocytes on the device, plunge it into liquid nitrogen, vitrify it, and then close the device. that is called open system, where the oocytes or embryos are going to be exposed to liquid nitrogen. And then we have closed system vitrification, where we load and close the system before exposing it to liquid nitrogen, so the cells do not come into contact with vitrification. So a lot has been said in recent times about risk of contamination through the use of open systems. Many people have, worried about the risk. They are worried that probably we are transmitting some infection to our oocytes and embryos because we are exposing them to liquid nitrogen. But we must remember that no such disease transfer has yet been reported, although an estimated so many thousands of embryos and embryos derived from frozen oocytes with open systems have been done. There is not a single infection that has been reported. So is this risk really applicable to real life IVF situation? We have to think about that. And what about effectiveness of both the systems? As far as the closed systems are concerned, the best survival rates reported in literature have been between 70 to 85%, whereas with open systems, survival rate of 98% or above has been reported even after oocyte vitrification. So I think a very pragmatic approach has to be used when we are deciding which system to use. And we cannot discard a method on hypothetical method that has given us such wonderful results for so many years on basis of hypothetical risks. Oocyte, I want to just say a little bit some important point about oocyte vitrification. It is a very, very special cell. It is very difficult to freeze oocytes than embryos. First and foremost, because of its shape. Oocyte is almost spherical in shape. So the equal permeation of cryoprotectants, penetration of cryoprotectants becomes difficult because of the perfect spherical shape of the oocyte. Then the number. Oocyte is just one. Embryos are multicellular. They have day 3 embryos are 8 cells. Blastocysts have so hundreds of cells. So even if few cells, one cell or few cells from the blastocyst they degenerate, there is a backup. Those embryos can still survive. But oocyte is only one. So if we end up damaging this cell in any way, there is no backup. We have lost the cell. The size. The oocyte is the largest cell in the human body. And in cryobiology, size is very important. Larger the cell, more difficult to vitrify it. So then we have zona pellucida hardening, we have cytoplasmic damage, we have meiotic spindle damages, membrane permeability issues. So oocyte has all these problems associated. So we have to have a very, very good approach when we are freezing our oocyte. The protocol has to be followed very, very well. The spindle is very sensitive to cryoprotectants at low temperature, and oocyte analyzed immediately after thawing displayed severe disorganization or disappearance of spindles. And incubation for 1 to 3 hours resulted in recovery of spindle. But we have to also consider oocyte aging. Now we know that the optimum time for ICSI of human oocytes is between 37 to 41 hours post-HCG. And we also know that inseminating the oocyte soon after thawing, when there is serious spindle disorganization, adversely affects the fertilization outcome. So we have to take care of both these competing aspects, oocyte aging as well as meiotic spindle recovery after thawing. So say we do our retrievals at 35 hours post-HCG, and we freeze our oocytes within 2 hours. So we are freezing at 37 hours post-HCG. So when you thaw, you're at 37 hours. You have to wait for 3 hours before you do ICSI to these oocytes for spindle recovery. So you wait for these 3 hours for spindle recovery. You are at 40 hours post-HCG. So you have taken care of oocyte aging as well. You are still within the time limit. So you are able to take care of oocyte aging only if you freeze within 2 hours. So remember that you have to freeze your oocytes 2 hours of retrieval or at 37 hours post-HCG. training in vitrification is extremely important, and adherence to the protocol is very, very important. Today, we are seeing a lot of reports in literature which say 100% survival for oocytes. Now, if we want 100% survival in our lab, we must adhere to the protocol 100%. If we start making our own changes in the lab, we are not going to be able to achieve these. Remember that these protocols have been devised by scientists with years of research in their fields. So we cannot change the protocols and we have to adhere to the protocol. So oocytes could not be successfully frozen for more than 20 years because of its high craft sensitivity. But today, anyone can craft preserve it easily and with over 98% survival rate, because today we have very, very robust and efficient craft preservation programs available. And it is very important to learn these protocols very, very well. And so finally, the secret of high survival rate, there is no one secret. You have to use the right protocol. And if you use the right protocol, if you use the right tools, and if you begin with a reasonable cell quality, you are bound to get 100% survival. So it is a cumulative effect of many small efforts that we are taking throughout the procedure to minimize the damage to the cells. So thank you very much. So vitrification is a wonderful technique with great potentials in IVF, and I think we must use it to its maximum potential to improve the efficiency of our IVF program. Thank you.
Thank you very much, Gaurav. You really brought us right into all the advantages and the carefulness that we have to have. And if I just may start with the first question, sperm freezing is much easier than oocyte freezing, correctly?
Yes, of course.
Sperm is much easier than oocyte freezing.
Yes. I mean, sperm freezing we have been doing for so many years. That was the first gamete that we had learned to freeze.
Because, of course, also in sperm we have some advantages with
the numbers is the advantage. We have millions of sperms. So even if we lose few millions, it doesn't matter really.
We will start with Dr. Kingsley Chukwu's question. When do we say the endometrium is not favorable for transfer?
I think this is a clinical question, Professor Mettler. You can probably answer it better.
Endometrium it's thin. It should be at least 8 to 10 millimeters. If it's that not, then we would consider something to do. Minu, you want to add something?
Yes, either the endometrium on the day of on the day of progesterone is not more than 7, or on the day of transfer not more than 9 or 10. Also, suppose you find some fluid in the endometrial cavity, even then you will not do the transfer in that cycle.
Dr. Neha, reasons for better quality embryos with minimal stimulation. That's already you, Gaurav. So you said minimal stimulation gives.
Yes. Yes. So it is a less dose of gonadotropins, the total dose, especially in poor responders. The total dose of gonadotropins that we end up giving sometimes goes to 5,000, 6,000 units, even higher, very, very high. And with minimal stimulation, we give first 5 days of clomazet citrate, and 150 IU of HCG is added from day 5 on alternate days. So we just give minimal dose of gonadotropins. And this has shown, when we compare the number of euploid embryos that we get with minimal stimulation versus conventional stimulation, it is much better. If you may have experience in your own labs, in your own centers, that for example, for PCO women, when you get 20 eggs, but the good quality blastocyst that you will get is only 3 to 4. So ultimately, it is only these 3 to 4 eggs, that is recruited initially and that are going to grow further, is going to be of higher quality. This is what I have observed over the years. When I see embryos with conventional stimulation and embryos with minimal stimulation, there is definitely a difference in the quality.
Minu, you take Dr. Neha's questions?
Okay, all right. Okay, so Neha is asking degree of damage to embryos during freezing and warming process.
This degree of damage, if done correctly, now we have, a lot of protocols available, lot of these ready-made media available, which do not have any damage. So if you follow the protocol very, very well, then there is practically no damage. In fact, now with pre-implantation genetic testing, we are freezing our embryos sometimes twice, sometimes three times. We have, so say for example, we have frozen oocytes. We thaw the oocytes, we create embryos, and we freeze these embryos. We transfer one embryo probably, and we freeze the rest embryos. There is no damage with multiple freezing, thawing. So if done correctly, there is really no damage.
Are results of oocyte freezing comparable to embryo freezing?
Embryo freezing is, of course, much easier. Oocyte freezing has a much, much higher learning curve. So, even when we started oocyte freezing, for me to very comfortably say that I don't care whether I get fresh donor eggs or frozen donor eggs, it took almost a year for me to come to that stage. So oocytes, as I had shown in that slide, are very, very sensitive. So oocyte freezing has to be done very carefully. You have to handle oocytes extremely carefully. You have to use a very efficient protocol to freeze the oocytes. And again, a very high learning curve. Whereas embryo freezing is much easier. We have learned to freeze embryos almost, so many years ago, but it is only since last 5 to 10 years that we are comfortable in freezing oocytes.
Ali, you want to unmute yourself and make a comment to that? Unmute yourself first. Unmute.
Dr. Ali, you need to unmute yourself first.
Unmute. Du musst das wegnehmen, geh auf Mute. Okay. Now, speak again.
Now? Okay, yes.
So did you want
Gandhi is correct. The oocyte freeze is more difficult than embryo, but survival is very good.
Okay. Dr. Kairavi is asking impact of using frozen oocytes on embryo quality. Embryos obtained using frozen oocytes be re-vitrified.
So again, I would like to emphasize the importance of the protocol that you use. Absolutely 100% adherence to the protocol. Do your research, research the literature, see what everybody is using, people who are getting 100% survival for oocytes, what protocol are they using, choose that protocol and follow it to the T. If all this is done carefully, if you maintain the timelines, again, freeze your oocytes within 2 hours of retrieval, wait for 3 hours post-thaw for the complete spindle recovery, then whether you use fresh oocytes or frozen oocytes really does not matter.
But the second is important.
And second, can embryo obtained using frozen oocytes be vitrified? Absolutely. There is absolutely no problem in vitrifying.
So if you thaw an embryo and then you are not transferring them, you can refreeze without any problem.
Absolutely. If we have these protocols now available where repeated freezing thawing is not making any difference.
Not any difference. Okay. Ali, do you have any opinion for that?
How to?
Do you refreeze sometimes oocytes or embryos once you thawed them?
We didn't do it.
Because I remember we were always careful, but it's interesting for me to hear that you say doesn't any difference, because we thought not to do it once. That's why we wait and see how the embryo develops, and only then thaw the next one if we want to transfer one.
No, so Professor Mittler, now we have, earlier, say about 5 to 7 years ago, we were doing day 3 freezing. So we have lot of embryos that are frozen on day 3. Now, if the patient has undergone 2 or 3 repeated failures with those frozen oocytes, and if they come back to us now we have one more thing to offer them. Now we are doing more and more of PGT. We do pre-implantation genetic testing. So what we do is we thaw out all these day 3 embryos, we grow them up to day 5, then we do a trophectoderm biopsy and we freeze those blastocysts. And when we get the PGT report, then we will, thaw the normal blastocysts and do it, and we are getting very good results.
So these embryos are undergoing the process twice.
Twice.
Yeah.
So twice I have experienced so many times in my own lab, and I think many people.
Yes.
Because this happens very often that we have already frozen the embryos, and if the patient undergoes a failed transfer, we want to then do a PGT, so you have to refreeze that.
The first paper of Alan Tronson on vitrification, he said, do not refreeze. And I discussed that with him many times. He said, well, not yet. Maybe that comes sometime. So he's not.
I think we have come a very long way in vitrification.
Minu, you take the next question.
Okay. How to determine that the patient requires minimal stimulation or not? Again, a very clinical question. Yeah.
I think the AMH level, the ASC level, and even probably the past failed transfers, you have to look at all these things.
Basically, poor responders,
Yes.
previous stim failure. Sometimes they do not want to again take that many injections, so you can also go for a minimal stimulation protocol.
Low PCO patients, low responders, some you have to go a long time till the estrogen is finally rising. It may be 3 weeks, and you don't want to push in because that's not helping. But mostly you learn that from previous failures, as Minu said. Yeah. Okay, Minu, next one.
Okay. Can you, does minimal stimulation mean use of oral ovulogens only, like clomiphene citrate or letrozole? No.
No.
You add HMG.
Yes.
Explain in detail of oocyte vitrification. So I have a video to show, but we don't have time. Maybe would you also have a video to show the vitrification technical process they want to know?
I have a video to show. I can send it to the participants.
Okay, fine.
I can send it.
You can send it to either to me or to Yasin, so they will share.
Sure. I will do that.
Show. So I don't know. We have the time, or we should go on the questions.
We should carry on. We need to finish it.
Okay.
The questions.
Genetic damage with vitrification. How is it prevented?
Well, now we have certain studies, many studies. I remember one study from Japan that is, almost 900 or 1,000 children studies, which shown that there is really no difference in the birth anomalies between fresh children born after fresh embryo transfers with IVF and frozen and after vitrification. So, not really.
Okay.
Can you suggest the best vitrification media? Do you have any names? Best commercial vitrification media?
I can say what I'm using in my lab.
Good.
Use Origin.
I don't know. It's good to use. We use Cryotech vitrification media.
Yeah, correct.
Minu, you take the next one.
Yes. Do you have a better pregnancy rate by operating all ICSI principle in your facility than conventional, even if there is no need for ICSI? Kinve Igvilo.
So that is also
ICSI for all. Do you think that is better, or ICSI plus IVF?
What do you think, Coral?
I don't believe in ICSI for all. So, right from the beginning, I've not been a proponent for ICSI for all. I like to decide only based on semen parameters and probably some past failures. So I still do a lot of conventional IVF. Even with my minimal stimulation IVF, where we have just 1 or 2 oocytes, if normal semen parameters are normal, I'm very comfortable doing IVF.
Many countries, ICSI, like in our country, is costing much more than IVF. So the companies are not carrying this. So we are very careful to offer ICSI only if it's really necessary. And the patient pays for 10 eggs that are ICSI, or how you say, she pays a lot more, maybe €1,000 more than she would pay if it's done by IVF, because every egg has nearly €100 of costs. So that is a big factor. But the basic question, Minu, how would you answer? Do you ICSI all of them, or how do you handle it?
Yes, actually at our center, because we have a visiting embryologist, we do ICSI for all. But I agree with Goral that that should not be the advised protocol. Yeah.
I think there is definitely not, we do not get better pregnancy rates by doing
I
it.
agree with you. I agree with you. Yes.
Quickly, because we are in time lag, if the embryos are frozen for longer duration, does it affect the embryo quality? You said the 20 years, you wouldn't go over it. Embryos frozen for 15 years, frozen for 5 years, is there any difference? Goral.
No, not really. I think recently there was some paper showing that there is a slight difference, but there was, I think I saw some limitations of the paper later on cited. So I don't think there is a difference personally. I have, seen differences. I think the longest I've used embryos is frozen for 12 years, and it had resulted in a successful pregnancy.
There is a new device called InvoCell, where the lady carries the mixture of sperm and her follicles in her vagina for 6 days before the transfer.
Before we have to stop? What does that mean? Yassine, do we have to stop?
No.
Okay.
Why?
Can you answer?
We need to start from the start, Dr. Minu. You left it 7, 8 questions.
Okay. There
From
is,
start.
okay. Goral, there is a new device called InvoCell.
Yes.
Which is placed in the vagina, which carries a mixture of sperm and her follicles, maybe oocytes,
Yes.
in her vagina,
Yes.
for 6 days before the embryo transfer.
Yes.
Yeah.
So I think this is advocated for countries which do not, places which do not have budget for a full-fledged lab with incubator. So what they do is the egg retrieval is done and the sperm is prepared, and they do the, either ICSI or mixing of the insemination, and then it is placed inside the uterus.
In the vagina, which acts as a natural incubator.
Yeah, which acts as a... Yes.
So Kamat is asking, would you recommend ICSI for fertilization of frozen oocytes?
Yes, because for freezing oocytes, you have to remove the cumulus, and you have to do ICSI. You cannot do conventional IVF to frozen oocytes.
What are the indications for MAX test? Minu, you already answered.
Yeah. Yeah. What are the indications for MAX test? MACS.
So as I said, MAX is a sperm separation technique. It is not a test.
Yeah.
It is a sperm sorting device, and it is recommended for patients with probably high DFI, high sperm DNA fragmentation index. So MAX helps to isolate functionally the normal sperms. So it is recommended for poor quality and high DFI semen samples. As a sperm separation technique, it is not a test.
Right, right.
Right. Ali, you want to say something to Max?
Max, I have already shown it. It is separation technique for the sperm with DNA integrity. If you don't separate it, maybe then you will get low fertilization or later abortion.
Okay, so I think we got all the questions. Thank you, dear colleagues.
There are still, I think, Dr. Lilo, still there are 7, 8 questions.
No, we have answered all.
No, you check it one more time. You can read.
We answered. Thank for the comments the colleagues did for us, and we are happy that you liked the first day, and we wish you a nice evening, afternoon, whatever is ahead of us. And Yassine, if you can find out a question that was not answered, please tell us.
It is there. It is in the QA box.
Which one? In the chat box?
Yeah, QA box. I think from Aisha Adil.
Okay. Sperms can also be frozen and thawed what is the procedure? Procedure for sperm freezing and thawing, Goral.
So she
Semen freezing and thawing.
Maybe
Okay.
Professor Salmasi can take it. I mean, it's a whole different procedure, semen freezing and
Yeah,
thawing.
Dr. Ali, can you answer this question?
About the sperm freezing?
Yes.
Yes, yes. Yes, it is relatively easy, but you have very low, sometimes yield results. You lost in motility, and maybe sometimes you have the reduced number of motile sperm. So this is very okay, very good. Can you do?
I think we can show tomorrow, maybe in the beginning, a video of freezing and thawing, and just for the technical purpose. Today it's too late, and we will now close. Gaurav, we had you only one time with us. We thank you very much for your participation. It was lively, very.
It was a pleasure to be here, Professor.
It was nice that you were with us, and we thank all the other faculty for today. Minu, you have a last word?
No, I thank Professor Ali and Dr. Goral. Both of you made everything very clear about the semen, oocytes, and the embryos. So I think you took us to the lab with all your dishes and your techniques. So thank you very much.
Thank you. Pleasure to be here, Dr. Minu. Thank you.
Thank you.
Thank you very much.
Thank you. Thank you, Dr. Goral. Thank you, Dr. Ali.
Thank you.
Thank you. Thank you, Dr.
Bye-bye. Bye.
Tomorrow.
So Yasin, you give me a call later.
Okay.